definitely there will be a protrusion or prolapse of a mass. But again, foul smelling का कोई logic समझ नहीं आता in this patient again. Okay, and usually rectal prolapse is also a painless condition. It does not cause a lot of pain. There is only discomfort क्योंकि मास बाहर आ रहा है ना, but pain नहीं होता. Pain का reason ही नहीं है कुछ as such. ठीक है? So that's the reason why it can be a likely case of cancer itself. ठीक है? Now, cauliflower-like mass is seen, which definitely says it is a case of cancer because cauliflower-like mass is only seen in a case of cancer. And biopsy reveals that it is a case of squamous cell carcinoma of the anal verge. Anal verge is nothing but the anal opening. वहाँ पे एक squamous cell carcinoma है. What will be the next line of management? So, it is a case of anal canal cancer. And anal canal cancer is treated by chemo radiation. What is that regime called as? Negro's regime. Please remember the treatment is known as the chemoradiation is what is known as the Negro's regime. Please remember that. No issues with this, anybody? Please remember this properly. If it is a case of this was the most common type of anal cancer is squamous cell carcinoma or it is a adenocarcinoma. Squamous cell, because the normal lining of anal canal is the squamous epithelium. But sometimes there can be adenocarcinoma of anal canal and that has to be treated like a rectal cancer. ये बोला था मैंने, adenocarcinoma of anal canal has to be treated like rectal cancer. जल्दी से, अगर anal opening से मैं देखता हूँ, okay, anal verge से या anal opening से, if the cancer is in the rectum, okay, I'm talking about a rectal cancer. If the cancer is more than 5 centimeters from the anal opening, treatment. अरे surgery रे, more than 5 centimeters from anal verge. Low anterior resection, that is removal of rectum as well as sigmoid colon, that is known as low anterior resection. Please remember. Okay, if the cancer is within 5 centimeters of the anal verge, सब surgery में दिखवा चुका हूं मैं. If it is within 5 centimeters from the anal verge, low anterior resection में sphincters are saved or sphincters are damaged. Saved. Okay, sphincters are saved. But if the cancer is within 5 centimeters from the anal opening, can you save the sphincters at any cost? No. अब damage होंगे ही. तो इसमें कौन सी surgery करते हैं अपन? One operates from abdomen, one operates from perineum. That is called as abdominoperineal resection, APR. With now, as the sphincters are damaged, can we leave the patient on his own? Can you pass your stools via anal canal? No. Otherwise, तो चलता ही रहेगा. रुकेगा क्या वो? नहीं. जैसे ही खाया बाहर निकल गया. ठीक है? So that will happen. Therefore, we have to close the anal canal and we have to make an opening on the anterior abdominal wall. That is called as the colostomy. But this time, temporary or permanent? Permanent colostomy has to be done. Okay? No issues with this, anybody? And rectal canal is only one cancer among the colorectal cancer which can be treated with radiotherapy. Baki koi bhi colonic cancer cannot be treated with radio. Now, important is please remember which HPV is associated with anal canal cancer. HPV, ये cauliflower like mass बोला है ना उन्होंने, so more likely it has been a case of anogenital wart which has progressed into an anal cancer in the patient. HPV 16 and 18. Warts are caused by 6 and 11, but cancer is always caused by 16 and 18. So if they are saying cancer, it has to be a case of 16 and 18. Please remember, human papilloma virus. थोड़े दिनों पहले तक ये फेवरेट वायरस था तुम्हारे एग्जामिनर का. ठीक है, हर एग्जाम में एक या दो क्वेश्चन होते थे इससे. No issues with this, anybody? That's important. Now, in a case of colorectal cancer, what is the tumor marker? Serum CA, that is carcinoembryonic antigen. What is the appearance on barium enema? ऐसे मत करो रे. हाँ बोलो फिर. Apple core appearance. Please remember. Investigation of choice. Colonoscopy plus biopsy. Colorectal cancer की बात चल रही ना भाई. Staging investigation of choice. T&M staging, MRI, TNM staging, मतलब overall staging, PET, CT, distant metastasis के investigation of choice, PET, positron emission tomography. For anywhere distant metastasis, investigation of choice is a PET scan. What is the dye used? 18 FDG, fluorodeoxyglucose, half-life 110 minutes. Sub previous year questions है, ठीक है? That's important. No issues with this, anybody? Chalo. Question number 173. A 25-year-old male met with a bike accident and brought to the emergency department. On examination, his vitals are systolic blood pressure is 90/60 millimeters of mercury. That means hypertension या hypotension. Hypotension में है patient. Along with that, the respiratory rate is pulse rate is 140 beats per minute. That means tachycardia. Hypotension and tachycardia suggest you of shock in a patient. That means hemodynamically unstable patient. As the patient is having bike accident after which he is presenting a shock. This shock will be more likely a case of hemorrhagic shock. That is due to extreme blood loss. That will land up the patient into hypovolemia. So it is a case of hypovolemic shock. Urine output starts decreasing from which stage onwards? How many stages are there for hypovolemic shock? 4 stages are there. Class 1, 2, 3 and 4. Class 1, how much percent of blood loss? This has been the question. It is 0 to 15% of blood loss is class 1. Class 2, टेनिस से याद कर लो 15 to 30% of blood loss. Class 3, 30 to 40% of blood loss. And class 4, more than 40% of blood loss. Question कौन सा था? ये था. When there is 30 to 40% of blood loss, which class of hypovolemic shock the patient is in? The patient is in class 3 of hypovolemic shock. Amount, if there is 500 ml of blood loss, class 1. 1 liter, 2. 1.5 liter, 3. And more than 2 liter, 4. Can anybody tell me which is the most common fracture known to cause hypovolemic shock? Pelvic fracture. It causes 1.5 to 2 liters of blood loss, followed by femur fracture, which causes 1 to 1.5 liters loss. इसीलिए in a case of pelvic fracture, we immediately tie a pelvic binder. Very good. Now, if I talk about class 1 hypovolemic shock, यहाँ पे तुम blood donation करके आए, ये याद रखना होता है. कुछ होता है क्या तुम्हें? कुछ नहीं होता. So class 1 में pulse rate is normal, systolic blood pressure is normal, urine output is normal. But blood donation के बाद क्या दिया जाता है तुम्हें? Fruity. That means here we will manage the patient with oral fluids. Next, class 2 hypovolemic shock. Class 2 hypovolemic shock is nothing else but here 50 to 30% of blood loss is there. Now, blood pressure will start decreasing. But जैसे ही blood pressure थोड़ा भी decrease होता है, what will happen? The body will try to compensate. Body will try to increase the blood pressure. And अगर blood pressure बढ़ाने के लिए compensate करती है body, what will the body do? The heart will try to beat faster. That is, pulse rate will increase. There will be tachycardia. So if they ask you that the pulse rate increases first time, in which class of hypovolemic shock? Answer is class 2. And what is the body trying to do? Compensation. Therefore, class 2 can be called as which phase? Compensatory phase of hypovolemic shock. Okay, now here, as the pulse rate is increasing, the blood pressure will be maintained. It will be normal. But what will happen? If there is adequate blood supply to the kidneys, urine output will also be normal. But if there is not adequate blood supply to the kidneys, urine output will start decreasing. So in case, not all patients will have decreased urine output in class 2. Okay. But if they ask you which is the first phase in which the urine output will start decreasing, answer is class 2 of hypovolemic shock, can also be called as moderate shock. Okay, here the management will be done by IV crystalloids. Management will be done by IV crystalloid. What are crystalloids? Ringer, lactate, and normal saline. Next is class 3 of hypovolemic shock, definitely. Here, what will happen? Now there is so much of blood loss, even if the heart will beat lot, okay, heart will beat very fast, then also will it be able to increase the blood pressure now? No, क्योंकि blood ही नहीं है body में, तो क्या blood pressure increase करेगा? That's the reason why it is the first phase where the blood pressure will start decreasing. It is the first phase where the blood pressure will start decreasing. And now pulse rate is still high, but still the blood pressure is not able to be maintained. Therefore, as the body is trying to compensate, but it is not able to. So therefore, class 3 can be called as decompensated phase of shock. Class 3 is called as decompensated phase of hypovolemic shock. And here, as the blood pressure is decreased, definitely the urine output will start decreasing further, and that will cause oliguria in the patient. Okay, here management will be done by IV crystalloids plus colloids. What is the ratio? 3:1 nahi re bhai, 3:1. 3 parts of crystalloids and 1 part of colloid. If that is not possible, we can just give blood transfusion, because blood also acts as a colloid. Okay. Next important is in cases of class 4 hypovolemic shock, here more than 2 liters of blood loss. Pulse rate मिलेगा क्या? Pulse मिलेगी क्या? नहीं. तो pulse is not recordable. Systolic blood pressure is not recordable. Urine output is almost nil. That is called as anuria. And here the management will be done by massive blood transfusion. No issues with this, anybody? That's what it is. Now, urine output will start decreasing. First in which stage? Class 2 of hypovolemic shock, that is also known as moderate shock. This was a previous year question. हाँ, तो बीपी डिक्रीज थर्ड स्टेज में होता है, बट याद रखना इंपॉर्टेंट है, बीपी अगर हाई भी है, दैट डज नॉट मीन देयर इज एडिक्वेट ब्लड सप्लाई टू द किडनीज. ओके, बीपी अगर हाई भी है, दैट डज नॉट मीन एडिक्वेट ब्लड सप्लाई टू द किडनीज इज मेंटेन. फर्स्ट प्रायोरिटी तुम्हारे बॉडी की होती है ब्रेन. तो अगर बीपी हाई भी है तो ब्लड प्रेशर पहले, ब्लड फ्लो पहले उधर जाएगा, किडनीज को बाद में जाएगा. ठीक है, नो इश्यूज विद दिस एनीबॉडी? दैट्स इंपॉर्टेंट. Now, question number 174. During the formation of an embryo, if blastocyst splits on day 9 to 13, it will result in which type of twins? Now, usually twins are of two types. One are called as dizygotic twins, other called as monozygotic twins. Dizygotic matlab there were two ova and two different sperms have fertilized it and two zygotes have formed. ठीक है, तो पहले से दो 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 था सब कुछ, that is a dizygotic twin. But some other condition will be एक ही ओवा था, एक one sperm has fertilized it, one zygote was formed, then that zygote was divided into two and now the twins are formed. So as these twins are formed from a single zygote, that will be called as a monozygotic twin. Now please remember, dizygotic twins, इनका membranes भी अलग होंगे, इनका placenta भी अलग होगा. Membrane is called as amnion, placenta is called as chorion. So these will be DCDA, that is dichorionic diamniotic twins. दीदी जिसको बोलते हो. Next is monozygotic twins. Monozygotics के 30% twins are usually again dichorionic diamniotic twins. If the split occurs within 3 days, okay, split occurs within 3 days or 1 and 2 days, ऐसा बोल सकते हो. ठीक है, then it will form the dichorionic diamniotic twins. मतलब अगर split जल्दी हो जाता है तो सब कुछ अलग अलग होगा. But अगर split बाद में होता है, that means if the split occurs between 3 to 8 days, now they have to share their placenta. They have to share their placenta. Can you see there's single placenta but two membranes? So therefore this will be called as monochorionic diamniotic twins. That is called as MCDA twins. Okay, Modi twins भी बोल सकते हो उनको. ठीक है, monochorionic diamniotic twins. Next, if the split occurs between 9 to 12 days, some books say 13 days as well. So 9 to 12 days तक अगर partition होता है, then definitely it will form momo twins. What are momo twins? Monochorionic monoamniotic twins. Please remember. That means they have to share the placenta as well as they have to share a single membrane itself. And lastly, if the split occurs after 12 days, now these will be called as the conjoined twins, also known as the Siamese twins. Now, please tell me which are the most common type of twins. Options are DCDA, MCDA, MCMA, and conjoined twins. Most common type of twins. कंजॉइंट वाले हाथ उठाओ जल्दी से, जल्दी जल्दी, कोई दिक्कत नहीं, गलत हुआ तो गलत हुआ. कंजॉइंट वाले, मोमो वाले, मोनोकोरियोनिक मोनोएमनियोटिक. पता चल दूसरी भी गलत हो सकते हैं, तो अपना हो तो हाथ उठाओ, कोई दिक्कत नहीं. मोनोकोरियोनिक मोनोएमनियोटिक, मोनोकोरियोनिक डायएमनियोटिक एंड डाइकोरियोनिक डायएमनियोटिक. वेरी गुड. बाकी लोग, मोस्ट कॉमन टाइप ऑफ ट्विंस आर डाइजाइगोटिक और मोनोजाइगोटिक. all dizygotic twins are, all dizygotic twins are 30% of monozygotic twins are. Overall most common will be, सबके एक तो सबसे ज्यादा कॉमन डाइजाइगोटिक ट्विंस है, पूरे के पूरे डाइजाइगोटिक दीदी ट्विंस है. 30% ऑफ मोनोजाइगोटिक भी दीदी ट्विंस है. तो ओवरऑल मोस्ट कॉमन विल बी द डीसीडीए ट्विंस ना भाई. दे विल हैव सेपरेट प्लेसेंटा एंड अ सेपरेट मेम्ब्रेन. ये जो तुम क्वेश्चन रट के बैठे हो ना, ये क्या है पता है? मोस्ट कॉमन टाइप ऑफ मोनोजाइगोटिक ट्विंस आर एमसीडीए ट्विंस, मोनोकोरियोनिक डायमनियोटिक. और भाई मोमो ट्विंस तो 1% होता है. ठीक है, प्लीज रिमेंबर दैट. So important is, please remember, if they ask you most common type of twins, answer should be DCDA twins, dichorionic diamniotic, because all dizygotic twins are DCDA and 30% of monozygotic are also DCDA twins. Whereas if they ask you which are the most common monozygotic twins, which are the most common type of monozygotic twins, then your answer can be Modi, that is MCDA twins, monochorionic diamniotic twins. समझे अभी difference? So don't make a mistake again, please. ठीक है? So if the split is occurring between 9 to 13 days, कौन से type के twins बनते हैं? Momo twins, that is monochorionic, monoamniotic twins. No issues with this. What is the shelf life or what is the lifespan of a ova? Single best answer. 24 hours. Okay. What is the lifespan of a sperm? 72 hours usually. ठीक है? Now important. जब fertilization होता है, fertilization. What is the best site for fertilization? Ampulla. Please remember ampulla. ठीक है? Then after fertilization, what is formed? Zygote. Okay. Zygote में क्या होता है फिर? Division. Okay. Division के बाद क्या होता है? 2 cell stage, 4 cell stage, 8 cell stage, 16 cell stage. 16 cell stage is called as morula. It is formed on third day morula बनता है. Advanced morula is 32 cell stage. Then after advanced morula, then there will be a cavity inside that is called as a blastocele, जिसमें fluid होगा, and the complete structure will be called as a blastocyst. Implantation occurs in which stage? Blastocyst वाला stage में. Okay, the blastocyst comes or enters inside the uterine cavity on day 5 usually. ठीक है? It enters into the uterine cavity on day 5, but implantation starts on day 6 onwards. Day 6 to day 9 is the time of implantation usually. ठीक है? And then definitely the further embryo is usually formed. कोई दिक्कत नहीं है, तो please remember this. ठीक है? So that is important to be remembered. What is the most common complication of twins which occurs? Twin to twin transfusion. जब arteriovenous connection हो सकती है. ग्रोथ डिस्कॉर्डेंसी. ग्रोथ डिस्कॉर्डेंसी बड़ा हो गया, दूसरा बच्चा हो गया. But that without even the transfusion तभी होता है when there is fistula between both of them. ठीक है? So that's the basic difference. No issues with this anybody? Please remember. Question number 175 now. A patient comes with micaceous scales. Very easy. Silvery mica like scales. ये जैसे ही आता है diagnosis हो जाना चाहिए. Micaceous scales over the extensors aspect with pitting of nails. Pitting of nails is known as thimble nails. Pitting of nails is known as thimble nails. That's the most common nail finding in cases of psoriasis. And there is also involvement of scalp. These findings are consistent with which diagnosis? Answer is directly psoriasis vulgaris. मैंने कल एक टर्म बताई थी, pityriasis. Pityriasis means स्केलिंग. तो जहां भी पिटायरियासिस है मतलब स्केलिंग लीजन है. एंड वल्गैरिस का मतलब होता है मोस्ट कॉमन. So wherever vulgaris comes, that is most common. Pemphigus vulgaris, most common type of pemphigus. Psoriasis vulgaris, most common type of psoriasis. Ichthyosis vulgaris, most common type of ichthyosis. ठीक है? So vulgaris means most common. You need to remember that. ठीक है? तो psoriasis में which kind of scales are formed? Which kind of lesions are formed? There are usually rashes with silvery mica-like scales on it. Extensor or flexor aspect? Extensor aspects are commonly involved. Scalp can also be involved in a case of psoriasis, please remember. Okay, if I talk about psoriasis, definitely this is the silvery mica-like scale. Apart from that, we know that in some conditions there can be pustular psoriasis also. That means pus can be present inside the psoriatic region. So pustular psoriasis is known as von Zumbusch disease. Important. Next, normally psoriasis occurs on extensors or flexors, extensors. But if it affects the flexular areas, then it is called as inverse psoriasis. That is in the inframammary region, inguinal region or the axillary region. इसको बोला जाता है inverse psoriasis. Next important, psoriasis during pregnancy is known as, और ये ऑप्शन में आता है, they never say psoriasis in pregnancy. They will give the term impetigo herpetiformis. Impetigo herpetiformis is nothing else but psoriasis during pregnancy in a patient. Please remember. Okay? Whereas when the whole body is red in color, that is what is called as a erythrodermic psoriasis. And most important, ये recent question है तुम्हारे exam का. Raindrop like lesions. Okay? Raindrop like psoriatic lesions are suggestive of guttate psoriasis. Okay? No issues with this anybody? Important, if I take a biopsy in a case of psoriasis, what will be seen definitely? I'll see hyperkeratosis. What is hyperkeratosis? Thickening of stratum corneum. Okay, it is thickening of stratum corneum, I'll see parakeratosis. What is parakeratosis? Normally, very good. Normally, the stratum corneum cells do not have a nucleus. But in this condition, the stratum corneum cells will have a nucleus. That is what is called as parakeratosis. Apart from that, can you see the rete-ridges? How are they appearing? They are elongated rete-ridges. ठीक है, club shape भी बोल सकते हो. These are usually elongated rete-ridges, whereas sawtooth rete-ridges are a feature of. Sawtooth rete-ridges are a feature of. Very good. Lichen planus. Okay, so sawtooth rete-ridges are seen in cases of lichen planus, whereas elongated rete-ridges are a feature of psoriasis. Please remember that. Important again. They will mention spongiform pustules of Kogoge. A pustules inside on the biopsy is not pus collection. Pustules, abscess in the biopsy, if they mention, that means collection of cells. ठीक है, तो यहाँ पे collection of neutrophils होता है usually. That is what is called as a pustule. ठीक है, so spongiform pustule of Kogoge, usually in the stratum spinosum or the stratum granulosum, is a classical feature of psoriasis. Previous year question, that spongiform pustules of Kogoge are a direct answer, psoriasis. In recent NEET-PG 2022, question was, all among the following features are seen in cases of lichen planus, except one of the exceptions was spongiform pustules of Kogoge, because spongiform pustules of Kogoge are not a feature of lichen planus. They are seen in cases of psoriasis. ठीक है, important is that. Which microabscesses are formed in stratum corneum? तो collection of cells in granulosum या spinosum को क्या बोलोगे? Spongiform pustules of Kogoge. But collection of cells को in stratum corneum क्या बोलोगे? Munro's microabscess. I hope all of you are quite aware of this. M in P and P in M. What is this? Munro's microabscess in psoriasis and Potterier's microabscess in mycosis fungoides. What is mycosis fungoides? Cutaneous T-cell lymphoma associated with which virus? HTLV1, human T-cell lymphotropic virus. Please remember that. ठीक है? So Munro's microabscess is a feature of psoriasis. Potterier's microabscess is a feature of mycosis fungoides. Please remember, this is very important. ठीक है? So these are the important features. चलो biopsy एक बार repeat करना मेरे साथ. क्या क्या दिखता है? Thickening of stratum spinosum known as hyperkeratosis. Presence of nuclei in stratum spinosum known as parakeratosis. Rete-ridges की shape क्या हो जाते हैं? Elongated rete-ridges. Collection of cells in stratum spinosum and granulosum known as spongiform pustules of Kogoge. Collection of cells in stratum corneum known as Munro's microabscess, and Potterier's microabscess is a feature of mycosis fungoides. कोई दिक्कत नहीं है अब तक? Important, please remember this. ठीक है, so that is important. अगर pemphigus vulgaris होता तो pemphigus vulgaris में कैसे बुल्ले बनते usually? The bleps or the blisters or the bullae which are formed, they are flaccid bullae. Flaccid bullae, therefore they are easily ruptured. Okay, intraepidermal or they are subepidermal? Very good, they are intraepidermal. मतलब superficial या deep? These are superficial. So अब flaccid है, superficial है, intraepidermal है, so they will be easily ruptured or less likely to be ruptured? Easily ruptured. Therefore, in pemphigus vulgaris, these bleps or bullae are easily ruptured. In bullous pemphigoid, they are deep, they are subepidermal, they are beneath, and therefore they cannot be ruptured easily. Okay, so that's the basic idea. Oral lesions are only seen in pemphigoid or pemphigus? Oral lesions are only seen in cases of pemphigus. Oral lesions are never seen in cases of pemphigoid. That is the important differentiating feature. Okay, next important, 20 to 40 years of age group, that is young patients, are commonly affected with pemphigus. Whereas pemphigoid mein which age group is commonly affected? Elderly patient, around 60, 70, 80 years of age group. That's the important thing. Here, if I take a biopsy, what is seen on biopsy? Row of tombstone appearance. Graveyard में जाते हो ना, शमशान घाट में, कैसे दिखता है वो? Row of tombstone appearance, just like that. Apart from that, on immunofluorescence, which pattern is seen? Fishnet pattern. Because it is an autoimmune condition, there will be deposition of antibodies. IgG antibodies are deposited, and that gives us the classical fishnet appearance. If the patient is having a vesico-Bullard's disease, but biopsy does not show, or immunofluorescence does not show IgG, but rather IgA, that disease is, very good, dermatitis herpetiformis. Because please remember, in pemphigus as well as pemphigoid, the deposition is of antibody. अगर वो IgA बोल रहे हैं, then it has to be dermatitis herpetiformis. No issue. Dermatitis herpetiformis, there are bullae which are seen. Along with that, an important feature is itching. which is less likely seen with pemphigus and pemphigoid. Itching or pruritus is a very common feature of dermatitis herpetiformis. तीनों को कभी भी कंपैरिजन में पढ़ना होता है, so it becomes easier to differentiate क्योंकि तीनों में vesicles होंगे, तीनों में blisters होंगे. You have to differentiate between all of them. ठीक है? No issues with this, anybody? And pemphigus में the antibodies which are formed, it is autoimmune condition ना, the antibodies are formed against which proteins? Antibodies are formed against desmosomes. Which desmosomes usually? Desmoglein 3, desmoglein 1 usually. ठीक है? Against pemphigoid. Please remember, hemidesmosomes के against जो antibodies बनती है, those are seen in cases of bullous pemphigoid. Please remember, that's the basic idea. No issues with this, anybody? Calcium ATPase के against antibodies are formed in. It is seen in diarrheal disease and Hailey-Hailey disease. Antibodies against calcium ATPase are formed in diarrheal disease and Hailey-Hailey disease. Okay, that's important. At least remember the antibodies, guys. क्योंकि वो बहुत बार antibodies directly दे देंगे question में. They will say that the antibodies are found against desmoglein 1 and 3. Answer should be pemphigus. They'll say that the antibodies are formed against hemidesmosomes, that is BPAG1 and BPAG2. Answer should be directly bullous pemphigoid. They will say that the antibodies are formed against calcium ATPase. Answer should be directly diarrheal disease of familial pemphigus, that is Hailey-Hailey disease. Okay, or they will say that the antibodies are formed against desmoplakin. So answer should be immediately paraneoplastic pemphigus. No issues with this. And what is this condition? Complete dryness of skin showing fish-like scales. Ichthyosis. Very good. And this is the case of ichthyosis vulgaris. Okay, which is the most common type of ichthyosis. Most severe type of ichthyosis, anybody? Very good. Harlequin ichthyosis. क्या दिखता है वो बच्चे में? ये बहुत कॉमन क्वेश्चन रह चुका है तुम्हारे एग्जाम का. Harlequin baby में the, please remember, the skin of the baby is completely cracked out. Okay, the child is not alive. The child is dead always in case of Harlequin ichthyosis. Please remember, that is the most. बस image based question आता है. What is the likely diagnosis based on the following image? Answer is directly Harlequin baby or the Harlequin ichthyosis, most severe form of ichthyosis. Okay, question number 176. A 35-year-old lady is having complaints of bilateral drooping of eyes. सरकारी, ये तो इसको तो तुम लिख ही लो सरकारी क्वेश्चन. ठीक है, तो प्लीज रिमेंबर, 35-year-old lady having complaints of bilateral drooping of eyelids, and drooping of eyelid is known as ptosis. So the patient is having bilateral ptosis along with on watching television. That means watching television, exposure to a lot of light is a trigger factor. Then chewing muscle and shoulder girdle weakness hota hai. Patient is not able to chew, okay, properly because there is chewing muscle weakness and there is shoulder girdle weakness, which progresses throughout the day. Very important. Which progresses throughout the day. That means the patient symptoms are improving with activity or decreasing with worsening with activity. Worsening with activity. Rheumatoid arthritis, there was improvement with activity. Here there is worsening with activity or worsening towards the evening. Which of the following is the investigation to confirm the diagnosis of this patient? मेडिसिन में कौन था रे? टीएनडी नहीं, मैं मेरे मेडिसिन टीएनडी में कौन कौन था? मेरे टीएनडी में, हाँ. क्या है बेस्ट? इन्वेस्टिगेशन ऑफ चॉइस. शाबाश. हाँ, क्या मार्क किया है? टीएनडी. बस. Important diagnosis is what? Diagnosis is definitely myasthenia gravis. ठीक है, myasthenia gravis is usually occurring in middle-aged males or females. Important is the patient will have bilateral ptosis. Sometimes there can be asymmetrical ptosis, जैसे इस female में दिख रहा है. It can be symmetrical, it can be asymmetrical. Along with that, there will be muscle weakness throughout the body, and the muscle weakness will be progressing or worsening throughout the day. मतलब evening में और खराब हो जाएगा patient का हाल. ठीक है. Important is in this condition definitely what is formed at the neuromuscular junction. That is the neuron, and this is the muscle at the neuromuscular junction. क्या होता है? Acetylcholine receptors. Okay, neuron releases what? Acetylcholine. This goes and bind to the receptor, and then the signal is carried forward, and therefore the muscle will contract. इस patient में क्या हुआ है? There are antibodies which are formed against the acetylcholine receptor. Therefore, these antibodies will come and damage these acetylcholine receptor. Now, can the acetylcholine bind? No. Therefore, can the muscle contract? No. Therefore, the patient has muscle weakness usually. So, it is an autoimmune condition due to presence of anti-acetylcholine receptor antibodies. And the second can be anti-MuSK antibodies, muscle specific kinase antibodies in 10 to 15% cases. 90%, 85 to 90% cases में anti-acetylcholine receptor antibodies ही होती है. ठीक है? Now, important is if I see this patient is having myasthenia gravis, और अगर तुमने एड्रोफोनियम टेस्ट कर लिया, एड्रोफोनियम टेस्ट is usually, एड्रोफोनियम is a cholinergic drug or an anticholinergic drug. It is a cholinergic drug known to increase the levels of acetylcholine. ठीक है? acetylcholine देने के बाद अब ज्यादा acetylcholine दे रहे हो तो definitely it can somewhat can bind to the receptor and the patient will have improvement. So if after giving acetylcholine, if there is improvement in the symptom, that is a case of myasthenia gravis. But if there is worsening of symptom, patient में cholinergic crisis हो गया. तुम्हारे diagnosis के लिए डालो patient को cholinergic crisis में और फिर करो manage. प्रैक्टिकल है ना, लॉजिक है. एड्रोफोनियम टेस्ट बहुत पुराना, ऑब्सोलीट है, वो नहीं करते. वो कौन बता के गया एड्रोफोनियम टेस्ट इन्वेस्टिगेशन ऑफ चॉइस? निकालो मनीष सर के नोट्स, मैं देखता हूँ. बेसिक है ना, नोबडी टेल्स इट. एड्रोफोनियम टेस्ट वाज अ थ्योरेटिकल टेस्ट ओनली. अभी ऑब्सोलीट है, वो नहीं करा जाता. दिमाग से निकाल दो. मायसीनिया ग्रेविस इतना कॉमन क्वेश्चन है और तुम उसमें अगर गलती करोगे, इट इज योर मिस्टेक देन, आई एम टेलिंग यू. ठीक है? इंपॉर्टेंट इज स्क्रीनिंग टेस्ट भी क्या है? स्क्रीनिंग टेस्ट इज नॉट आल्सो एड्रोफोनियम टेस्ट. Screening test B is also antibody titer. That is anti-acetylcholine receptor antibodies will be a screening test. And the best investigation will be investigation of choices, single fiber electromyography, EMG. देखो ना इलेक्ट्रिकल एक्टिविटी है या नहीं मसल में, उससे अच्छा क्या हो सकता है? नथिंग ना. तो सिंगल फाइबर इलेक्ट्रोमायोग्राफी इज द इन्वेस्टिगेशन ऑफ चॉइस, गोल्ड स्टैंडर्ड इन्वेस्टिगेशन फॉर डायग्नोसिस ऑफ myasthenia gravis. Please remember this. Don't make a mistake again. Anti-PYQ voltage gated channel, voltage gated calcium channel antibodies are seen in cases of Lambert-Eaton syndrome. Very good. How to differentiate? Because Lambert-Eaton syndrome में भी क्या होगा patient में? Muscle weakness. क्यों? क्योंकि calcium channels are damaged. And as calcium channels are damaged, can the calcium go inside muscle? No. And calcium नहीं जाता तो contraction होगा क्या? No. So again, the patient will have muscle weakness. How to differentiate between myasthenia gravis and Lambert-Eaton syndrome? नहीं. Repetitive nerve stimulation. Repetitive nerve stimulation में if there is a decremental response, that is suggestive of myasthenia gravis. And repetitive nerve stimulation में if there is an incremental response, that is suggestive of Lambert-Eaton syndrome. Lambert-Eaton syndrome is a paraneoplastic syndrome associated with which cancer? Small cell carcinoma of lung. Small cell or oat cell carcinoma of lung has Lambert-Eaton syndrome. Second, SIADH. Third, Cushing syndrome. These are the paraneoplastic syndrome associated with small cell carcinoma of lung. Okay, with squamous cell carcinoma of lung, what is the paraneoplastic syndrome associated? Hypercalcemia. Very good. Overall in body, most common paraneoplastic syndrome is hypercalcemia. Most of the cancers in body cause hypercalcemia. Okay? Some carcinoids cause lung carcinoid or any carcinoid. कितनी बार क्वेश्चन हुआ है, डिस्कस ये. Carcinoid secrete a lot of serotonin and they cause serotonin syndrome, flushing, diarrhea, pruritus. बोला था ना? That's important. What is the drug of choice for myasthenia gravis? Pyridostigmine. Long-acting drug should be given. Long-acting cholinergic drug known as pyridostigmine. But to avoid the muscarinic side effect. क्यों? क्योंकि problem is not. The problem is that muscarinic receptors or the nicotinic receptors. It is mainly at the nicotinic receptor, NM receptor. So we don't want any muscarinic side effects, okay, like salivation, lacrimation. ये ज़्यादा नहीं होना चाहिए ना. So therefore we will give along with that atropine as well. So whenever you give neostigmine or pyridostigmine, if you don't want the muscarinic side effects, always combine with atropine. Neostigmine plus atropine is the drug of choice for which bite? Cobra bite. Scorpion bite के लिए drug of choice is Prazosin. ठीक है, चलो, moving further. Question number 177. A young patient developed sudden onset fever, agitated behavior for 2 days. No meningeal signs were noted. EEG reveals periodic lateralized focal temporal lobe spikes. Okay. CSF analysis. Previous year FMG question है. तुम्हें लग रहा होगा हमने बनाया? नहीं. ये बच्चों ने recall दिया हुआ है कि the EEG was showing periodic lateralized focal temporal lobe spikes. CSF analysis shows 60 cells which are predominantly lymphocytes. There are elevated proteins. There is normal CSF glucose. Which of the following drugs shall be started in this patient? There is no meningeal signs. So important is the patient is having fever. Okay. Along with that, they have not mentioned even about neck stiffness. Okay. So important is it is not a case of meningitis. Pehle to get it right. It is not a case of meningitis. They are mentioned about CNS symptoms like agitated behavior. Okay. They have mentioned that the patient is having EEG finding. मेनिंजाइटिस में ईईजी पे कोई प्रॉब्लम दिखेगा क्या? नहीं, क्योंकि ब्रेन इन्वॉल्व ही नहीं है तुम्हारा. ईईजी पे तभी प्रॉब्लम दिखेगा जब ब्रेन में कोई प्रॉब्लम हो. दैट मींस द इन्फेक्शन इज इन द brain. An infection or inflammation of brain is called as encephalitis. ठीक है? So definitely it is a case of encephalitis. What is the most common cause of encephalitis worldwide? It is HSV1, that is herpes simplex virus type 1. In India it is Japanese encephalitis. ठीक है? Important. And HSV1 is normally most common site for HSV1 encephalitis is the temporal lobe. Therefore, if I take a EEG of this patient, electroencephalography, क्या दिखता है उसमें? P-lead, that is periodic lateralized epileptiform discharge. Also can be called as periodic lateralized temporal lobe spikes. ठीक है? So that's important. P-lead भी देते हैं वो कभी-कभी directly. EEG shows P-lead. P-lead is nothing but periodic lateralized epileptiform discharge. मतलब temporal lobe में दिक्कत है ना, तो बस उधर ही abnormality दिखेगी. Now CSF analysis we do in encephalitis as well as meningitis. दोनों में किया जाता है lumbar puncture and then we will do a CSF analysis. 60 cells are seen which are predominantly lymphocytes. Now, which type of infection can be ruled out? Very good. Bacterial. As there are lymphocytes, it cannot be a case of bacterial infection. Okay. So it will be either fungal, it can be either viral or it can be TB, tubercular. Okay. So tubercular में short history होती है या long history होती है? Long history. यहाँ sudden onset दिया है. So we can rule out TB as well. Fungal and definitely viral are left with us. Important is fungal meningitis का fungal encephalitis का causes can be cryptococcus usually, ठीक है? And that is only seen in immunocompromised patient like HIV positive individual. And fungal encephalitis is very, very rare again. Viral encephalitis is more common. Please remember that, ठीक है? And most important, elevated protein तो किसी भी infection में दिखता है. So elevated protein is not diagnostic. Normal CSF glucose. ग्लूकोज कौन कौन खाता है? बैक्टीरिया, टीबी, फंगस. वायरस जिंदा रहता है क्या ग्लूकोज पे? नहीं. So if there is viral infection, CSF glucose will be absolutely normal. So if they say CSF glucose is normal, it is a case of viral meningitis or viral encephalitis that you need to think in terms. And viral encephalitis की most common cause is herpes simplex virus. So the drug of choice should be acyclovir for this condition. ये meningitis का टेबल जिनके पास नहीं है वो आज भरो और घर पे जाके लगाओ. बिकॉज मेनिंजाइटिस के कम से कम 2 क्वेश्चन आते हैं मेनिंजाइटिस प्लस एनकेफेलाइटिस मिला के. बैक्टीरियल, ट्यूबरकुलर, viral and fungal meningitis. Now jaldi se, first of all, whenever we will do a lumbar, what is the classical triad of meningitis? Headache, fever and neck stiffness, also known as nuchal rigidity. If fever is not present, then we can suspect subarachnoid hemorrhage. Without fever, only headache and neck stiffness are suggestive of subarachnoid hemorrhage. I've told you this was a recent FMGE Jan 2023 question. Don't make a mistake. Fever nahi hai, so it is not meningitis. Please remember that. Along with that, due to raised ICP, the patient can have projectile vomiting as well at times. ठीक है? Important. Most common type of meningitis is usually bacterial meningitis and most common causes. Yeah. Streptococcus pneumoniae, that is also known as your pneumococcus, definitely. Please remember that. Okay? Whereas tubercular meningitis cause we know it is Mycobacterium TB itself. And viral meningitis, the most common causes enteroviruses. Encephalitis is it is HSV1, but for meningitis it is enteroviruses. Okay? Fungal meningitis it is Cryptococcus neoformans. It is usually seen in HIV positive individuals. Now, if a patient comes to you with meningitis, which 2 signs can be elicited on clinical examination? Kernig sign and Brudzinski sign. Very good. Now, if you are performing lumbar puncture, what is the best side? L3, L4 usually. Then we will get the CSF. सबसे पहले जब CSF निकल रहा हो तो सबसे पहले 2 चीजें देखोगे तुम. क्या देखोगे? First you will see the appearance and second is the pressure with which the CSF is coming out. If the appearance is turbid, it is suggestive of bacterial meningitis. Fungal में भी कैसा होगा? Turbid. In tubercular meningitis, it will form a Very good. It will form cobweb coagulum due to the fibrin. Okay, cobweb coagulum. And in viral meningitis, it will be absolutely clear. Normal CSF भी कैसा होता है? Clear. It is colorless. So in viral, there will not be any turbidity, no coagulum, nothing. It will be clear. Pressure now. As it is an infection, definitely the pressure will be high in every case. Okay? So there will be opening pressure will be high almost in every case of meningitis. It might be slightly higher in cases of tubercular meningitis. Please remember that. Proteins, again it is an infection, it will cause inflammation, और जहां जहां inflammation वहां वहां proteins क्या होता है, ज्यादा होता है. तो again every case will have more number of proteins. So this is not a differentiating feature. Differentiating feature are these two. One is cell and second is glucose. Now important, only meningitis where there is neutrophils, that is bacterial meningitis. Okay. Normally, do we have neutrophils in the CSF? No, zero neutrophils. So if neutrophils are present in the CSF, diagnosis is straight away bacterial meningitis. In all the other types, there is only lymphocytes which are present. In all the other types, there are only lymphocytes which are present. Important, if there are more than 100 lymphocytes, it can be thousands also, thousands usually. More than 100, I'm saying bare minimum 1000, bare minimum 100. It can be 1000, 2000, any type. That is what is a case of tubercular meningitis. In viral, how much it would be? It will be a between 50 to 500 lymphocytes, and in fungal only 10 to 20 lymphocytes. Normally there are 0 to 5 lymphocytes in CSF. So 0 to 5 है, so don't make a diagnosis of meningitis. Okay, 10 to 20 lymphocytes are seen in fungal, 50 to 500 viral, and more than 100 thousands में in tubercular. ठीक है, glucose now जल्दी से. Important, कौन कौन ग्लूकोज खाता है? बैक्टीरिया, टीबी, फंगस. So CSF glucose will be low in bacteria, TB and fungal meningitis. More low in definitely bacterial meningitis. ठीक है? But it will be absolutely normal in cases of viral meningitis. That's the important feature. Investigation of choice for bacterial meningitis. CSF क्या? Very good. CSF culture. Culture से अच्छा कुछ हो ही नहीं सकता. ठीक है? तो CSF culture will definitely be the investigation of choice for bacterial meningitis. For viral, for TB, tubercular meningitis, CB not of the CSF. ठीक है? CB not or gene export of the CSF can be done. Then definitely for viral meningitis, PCR. Very good. PCR for viral meningitis. For fungal meningitis, cryptococcal neoformans. वेरी गुड. मैंने कल ही बोला था इन्वेस्टिगेशन ऑफ चॉइस फॉर क्रिप्टोकोकस न्यूफॉर्मेंस इज एलाइजा. बट अगर वो रैपिड टेस्ट के बारे में पूछते हैं, देन रैपिड टेस्ट विल बी, ये अगस्त का क्वेश्चन, रैपिड टेस्ट विल बी lateral flow assay for cryptococcal antigen followed by India ink stain. तो मैंने क्या बोला था? India ink stain is not specific for cryptococcus neoformans. It will only stain the capsule. Though it is rapid, it is not the best test. Rapid may be better test is lateral flow assay for cryptococcal antigen, and that was the previous year August 2020 FMG question. Treatment jaldi se now for bacterial meningitis, bacterial so antibiotics, third generation cephalosporins, drugs like IV, Ceph, Triac, zone definitely. ठीक है, please remember. For tubercular meningitis, ATT plus steroids are to be given to decrease the cerebral edema, because cerebral edema is highest with tubercular meningitis. Next, for viral, acyclovir. And finally, for fungal meningitis, that is cryptococcal, it should be LAM, that is liposomal amphotericin B, along with 5-flucytosine. ठीक है, नो इश्यूज विद दिस. तो meningitis का ये टेबल अच्छे से याद रख लो भाई. क्वेश्चन नंबर 178. A 78-year-old man was brought to the emergency room with progressive right arm weakness, dysarthria, and right facial numbness after 8 hours of onset. His blood pressure was 160 by 80 mm of Hg. There was a past medical history of myocardial infarction and hypertension. He underwent the NCCT head as shown below. What is the first line management for this patient? What is the provisional diagnosis? Stroke. Which kind of stroke can also be called a cerebrovascular accident, CVA? So it is a case of stroke or CVA. Which kind of stroke, anybody? So it is a case of, दो टाइप के स्ट्रोक होते हैं ना. एक होता है इस्केमिक स्ट्रोक ड्यू टू डिक्रीज ब्लड सप्लाई. दूसरा क्या, जिनको नहीं पता स्ट्रोक क्या है भाई, स्ट्रोक इज नथिंग बट डैमेज टू द ब्रेन. क्यों डैमेज होता है ब्रेन का? बिकॉज देयर इज डिक्रीज ब्लड सप्लाई टू सम पार्ट ऑफ द ब्रेन. डिक्रीज ब्लड सप्लाई के दो कारण है. वन, देयर इज सम ब्लॉकेज इन द वेसल. that will be called as ischemic stroke. दूसरा जो vessel supply कर रही थी वही फट गई है, that is what is called as a hemorrhagic stroke. So which is more common? Ischemic stroke. Ischemic stroke is due to blockage of the vessel. Blockage का most common cause is atherosclerosis. So that is the cause. Usually ischemic stroke can be of two types. It can be either thrombotic stroke, मतलब अगर blockage वही है, but it can also be embolic stroke. That means the thrombus was formed somewhere else, maybe in the heart, and from heart it has gone to the cerebral or the brain vessel, and now it is causing blockage. That is an embolic stroke. Most common type of stroke, as I've told you, ischemic, and ischemic may be embolic strokes are more common, not thrombotic ones. Please remember that. Okay? Now, important is if I talk about this, usually hemorrhage kaisa dikhta hai CT. In any case of stroke or any case of head injury, the first line investigation or the investigation of choice is always a NCCT head. On NCCT head, if we see something white, that is called as hyperdensity, and that is suggestive of bleed. So hemorrhagic stroke mein we will see something white inside the brain. Okay. Whereas in ischemic stroke, we will see something black, that is hypodensity inside the brain because there is decreased blood supply. इस CT में क्या दिख रहा है? Black appearance दिख रहा है ना? So is it a case of ischemic or a hemorrhagic stroke? It is a case of ischemic stroke. Important, due to decreased blood supply due to blockage. Now ये समझ गए कौन सी आर्टरी का ब्लॉकेज हो सकता है? Most common artery affected is the MCA itself, that is middle cerebral artery. दिख रहा है ना? It is the zone of the middle cerebral artery जहाँ पे ischemia हुआ है, जहाँ पे blackening दिख रही है. So it is the middle cerebral artery का blockage which is causing this stroke in the patient. And middle cerebral artery supplies a majority part of the brain. Okay, therefore the patient will have severe signs and symptoms. Now middle cerebral artery supplies the internal capsule. तो अगर internal capsule को blood supply नहीं मिल रहा, तो the patient will suffer from dense hemiplegia. What is hemiplegia? Plegia का मतलब होता है paralysis और weakness. Hemi का मतलब होता है half of the body. So dense hemiplegia मतलब I will have weakness or paralysis in half of my body. मतलब for example my right arm and my right leg are paralyzed. Q because there is some blockage in the middle cerebral artery. On which side? Right side or left side? Left side, because brain में क्या होता है? Cross innervation, therefore it is contralateral. That means left side of brain controlling my right body and right side of brain controlling my left body. So if I am having right sided arm weakness and left sided right sided leg weakness, that is suggestive. That means the problem is in the left of my brain. That means my left side of the middle cerebral artery is affected. Dense hemiplegia का मतलब होता है बिल्कुल ही हाथ नहीं उठा पा रहा. I am not even able to pick up my finger, because all the fibers which are supplying, they are collected at the level of internal capsule. Internal capsule is a collection of all the fibers. अगर उसको ही blood supply नहीं मिल रहा तो एक भी fiber काम करेगा क्या? नहीं. Therefore the patient will have dense hemiplegia if there is decreased blood supply to internal capsule. So due to that, definitely the patient will have arm weakness as well as there will be leg weakness. There will be dysarthria, that is difficulty in speech. Important is leg and arm weakness are ipsilateral or contralateral? अभी तो बताया. लेग एंड आर्म वीकनेस विल बी, अगर लेफ्ट साइड ऑफ ब्रेन गया तो राइट साइड ऑफ आर्म एंड लेग जाएगा ना. तो डेफिनेटली लेग एंड आर्म वीकनेस आर ऑलवेज कॉन्ट्रालैटरल, मतलब अपोजिट साइड में. बट फेशियल वीकनेस अगर वो बोलते हैं तो फेशियल वीकनेस इज इप्सिलैटरल. बच्चों याद रखना, फेशियल वीकनेस इज इप्सिलैटरल. ठीक है, नो इश्यूज विद दिस. तो दे आर सेइंग दैट द पेशेंट इज हैविंग right arm weakness, dysarthria, and there will be right facial weakness. Right facial numbness इसलिए because there is a extensive hemorrhage, extensive ischemia in the middle cerebral artery. So that means not only one side is affected, both sides are affected usually. ठीक है? His BP was 160 by 100 mm of Hg. There was a past medical history of MI and any case of atherosclerosis can develop MI. याद रख लो, atherosclerosis अगर coronary arteries में होता है तो MI होता है. Atherosclerosis अगर brain vessels में होता है तो stroke होता है. That's the only basic reason. ठीक है, that's important. He underwent an NCCT head that shows ischemic stroke. What is the first line management of this patient? Hemorrhagic stroke में क्या करते हो बताओ. चलो, hemorrhagic stroke में क्या करते हो? Hemorrhagic stroke में definitely if the blood pressure is too much high मतलब 220, okay, 220 से ज्यादा हो blood pressure, okay, if it is more than 220 by 120, then we will try to manage the blood pressure and then we will give IV nicardipine. बराबर, क्यों मैंने लिखवाया था ना, इंट्रा सेरेब्रल हेमोरेज इज नथिंग बट हेमोरेजिक स्ट्रोक इटसेल्फ. ओके, so that is what is IV nicardipine. Otherwise only go for observation if the BP is almost on the lower limit. ठीक है, important. Whereas if I talk about ischemic stroke, what is the first line management? Thrombolysis. ब्लॉकेज है ना, तोड़ो ना ब्लॉकेज को, दैट इज ब्लॉकेज को तोड़ोगे, थ्रोम्बस को तोड़ोगे, दैट इज thrombolysis. Drugs are altiplase, tenecteplase, retiplase. Usually thrombolysis should be done within a span of 4.5 hours usually. Please remember guys, internship तुम करोगे, important is there are a lot of emergency cases of stroke and MI which occurs. ठीक है, अगर तुम्हें ये नहीं पता कि वो पेशेंट स्ट्रोक का आ रहा है, तुम कुछ नहीं करोगे और पेशेंट मर जाएगा. टेक मेडिसिन सीरियसली. तुम्हें क्या लग रहा है, तुम अभी पढ़ रहे हो, ठीक है, दिस इज नॉट अबाउट द एग्जाम. नॉर्मली तुम्हारे पास पेशेंट आ रहा है, तुम्हें डायग्नोसिस नहीं बन रहा, क्या पेशेंट को ठीक करने वाले हो? तुम मेडिकल ऑफिसर होगे, प्राइवेट में तुम्हारे आसपास कोई नहीं होगा. लेट मी टेल यू, यू आर द मेडिकल ऑफिसर, तुमने एमबीबीएस करी हुई है. नर्स नहीं बताएगी तुम्हें क्या करना है, तुम बताओगे नर्स को क्या करना है. नर्स तो बस बीपी लेके, हाँ डॉक्टर साहब ऐसा ऐसा है. नर्स नहीं बताने वाली, यू आर द वंस हु विल टेल द नर्स. इसीलिए मेडिसिन इंपॉर्टेंट. तुम अपने सामने देखोगे पेशेंट मर रहा है, तुम कुछ नहीं कर पा रहे हो. It's not about your life, guys. It's about the lives of the patient who will be coming to you. They are trusting you. तुम्हारा प्रोफेशन मजाक नहीं है. I've seen people literally shaking in front of patients. यार अगर हमें स्ट्रोक और एमआई के डायग्नोसिस नहीं बन पा रहे तो क्या डॉक्टर बन गया हम फिर? क्या मतलब हमारा डॉक्टर बन के? याद रखना, एमडी मेडिसिन वाला हमेशा नहीं आएगा तुम्हारा. तुम आरएमओ हो, आरएमओ को ही मैनेज करना पड़ेगा प्राइमरी. तुम्हें लोडिंग डोज पता होने चाहिए एमआई के. चलो अभी नहीं, इंटर्नशिप में सीख लेना बैठ के. ये मैंने बहुत देखा है, पीजीज अपना काम कर रहा है, ये सैंपल निकालने आते हैं और निकल जाते हैं. अरे भाई, इंटर्नशिप किसके लिए होती है? सीखने के लिए होती है ना. शो दैट जील कि प्रैक्टिकल चीजें वही सिखाएगा तुम्हें. लंबार पंक्चर करो, बोन मैरो एस्पिरेशन करो, सेंट्रल लाइन डालो, इंट्यूबेशन करो, उससे सीखो कि क्या क्या करना है सर. यू एंड वो ऐसे ही नहीं सिखाएगा भाई, उसका काम करोगे तो वो सिखाएगा. गिव एंड टेक है वो. तुम उसको पैसा नहीं दे रहे हो कुछ भी. इंटर्नशिप का भरोगे तो हॉस्पिटल को भरोगे, पीजी को नहीं. पीजी से तो पीजी के काम करने पड़ेंगे, दैट्स बेसिक. आई सीन इंटर्न्स रनिंग. हमारे तो इंटर्न दिखते ही नहीं है हॉस्पिटल में. तो इंपॉर्टेंट है, बाद में पछतावा होगा. आई एम टेलिंग यू, इंटर्नशिप इज द टाइम. तुम्हारे लिए, बहुतों के लिए तो 2 साल की है. टेक एडवांटेज ऑफ दैट. डोंट रन अवे फ्रॉम योर वर्क. नो, सीखने की कोशिश करो. सिखाने वाले बैठे हैं, बट तुम्हारे अंदर वो सीखने की चाह होनी चाहिए. देन दे विल टीच यू फॉर श्योर. ठीक है, so that's important. So first, definitely first line management should be thrombolysis, that is break down the thrombus. And thrombolysis, as I've told you, it is done with altiplase, retiplase and tenecteplase. Okay, but it is only done if the patient presents to you within 4.5 hours of symptom onset. If the patient presents after 4.5 hours of symptom onset, you cannot go for thrombolysis. You just have to go for observation and close monitoring of the patient. अगर बीपी बहुत ज्यादा है, ओके, अगर बीपी बहुत ज्यादा, दैट इज मोर देन 220/120, देन ओनली गिव योर एंटी हाइपरटेंसिव ड्रग्स. क्यों? ये मैंने तुम्हें सर्जरी में, जब अपन सेकेंडरी ब्रेन इंजरीज कर रहे थे, सेकेंडरी ब्रेन इंजरीज आर ड्यू टू रेज्ड आईसीपी, कुशिंग स्ट्राइड देखा था, तो बताया था क्या होता है. ऑलरेडी ब्रेन को ब्लड सप्लाई कम है, ठीक है, दैट इज द सेरिब्रल ब्लड फ्लो इज ऑलरेडी लो. इफ यू ट्राई टू डिक्रीज द बीपी, द सेरिब्रल ब्लड फ्लो विल बी डिक्रीजिंग फर्दर. Therefore, in cases of head injury, बॉडी ही क्या करती है, बॉडी ब्लड प्रेशर को स्पाइक अप रखती है, so that अगर मीन आर्टेरियल प्रेशर ज्यादा हो तो सेरिब्रल ब्लड फ्लो भी मेंटेन रहेगा. अगर तुम बीपी को ज्यादा कम कर दोगे, ब्रेन का ब्लड सप्लाई भी कम हो जाएगा. ऑलरेडी उसको नहीं मिल रहा और तुम कम कर दो उसका. ठीक है, so that should not be done. So please remember, cerebral blood flow is equal to mean arterial pressure minus ICP, बोला हुआ है मैंने. ठीक है, so that's the basic idea. So यहाँ पे patient has presented to you after 8 hours. So can you do thrombolysis in a case of ischemic stroke now? No. So treatment should be observation with monitoring. Important is dual antiplatelet therapy will be started in the patient and the patient will be continued on it. But the first line management is not antiplatelet therapy. It is the adjunct therapy always. Dual antiplatelet therapy, that is aspirin plus clopidogrel. That is the treatment of choice I am saying, or the drug of choice for which condition? When the symptoms of stroke are lasting for less than 24 hours. Very good. It is a case of transient ischemic attack or the transient ischemic stroke. ठीक है, symptoms है but बहुत mild है and they improve within a span of 24 hours. That is the case of transient ischemic attack. For that, the first line management or the drug of choice will be dual antitherapy. No issues with this, anybody? If they have mentioned that the patient has come to you within 4.5 hours of symptom onset, तो तुम्हारा आंसर क्या होता बच्चों? C होता. That is treatment with tissue plasminogen activator. That is nothing but the thrombolytic agents like retiplase, tenecteplase and altiplase. ठीक है? Please remember that. No issues with this. And अगर BP patient का 220 by 120 से ज्यादा होता, then my management would have been IV nicardipine. Unless and until the BP is too high, I will not go for antihypertensives. Otherwise, I'll compromise the blood flow to the brain. That's the important thing. Blood BP को थोड़ा high level पे रहना तो कोई दिक्कत नहीं आती उससे. ठीक है? Question number 179. इंपॉर्टेंट है ये, देखो मैं एग्जाम के लिए अभी बता नहीं रहा, इंपॉर्टेंट है एग्जाम के लिए जिसको स्ट्रोक दिक्कत आती है छोड़ो, मेनिंजाइटिस ने मत छोड़ना यार, मेनिंजाइटिस का एक टेबल है, उसको करके जाने में कोई दिक्कत नहीं आनी चाहिए किसी को, और बहुत इजी क्वेश्चन होता है, सीएसएफ एनालिसिस से डायग्नोसिस बनना चाहिए। स्ट्रोक जिसको दिक्कत आ रही है अभी छोड़ो, बट प्लीज मेक श्योर वंस यू एंटर योर इंटर्नशिप प्लीज रीड स्ट्रोक थरली, एमआई थरली, ठीक है, तो दैट्स इंपॉर्टेंट। अभी छोड़ो कोई दिक्कत नहीं है, एक क्वेश्चन जाएगा भी तो इट विल नॉट क्रिएट अ लॉट ऑफ फेम, बिकॉज आई डोंट वांट टू क्रिएट इन योर लाइफ कि स्ट्रोक पढ़ते रहोगे बाकी सब चीजें भूल जाओगे, दैट शुड नॉट हैपन, बिकॉज स्ट्रोक इज डिफिकल्ट टू अंडरस्टैंड, बहुत इंपॉर्टेंट है वो। बट क्वेश्चन नंबर 179, a 50-year-old female known case of nephrotic syndrome. अब nephrotic syndrome is a hypocoagulable state और hypercoagulable state, hypercoagulable state, ठीक है। She took a long flight, मतलब history of prolonged immobilization, okay, so there is risk of nephrotic syndrome also, along with that there is risk of prolonged immobilization as well. And she took a long flight from New York to Delhi and started experiencing severe breathlessness and suddenly collapses at the airport. Chest X-ray has been given. D-dimer is elevated. Which among the following is the preferred treatment? पहले provisional diagnosis. काफ पेन बोला उन्होंने, एडिमा बोला काफ में, और डीवीटी क्या तीन घंटे में 12 घंटे में डेवलप हो जाएगा? DVT is different, guys. DVT is one of the risk factors. Not always DVT and pulmonary embolism occur hand in hand. याद रखो, दोनों चीजें अलग अलग है. DVT is a risk factor for pulmonary embolism. But even without DVT, there can be pulmonary embolism, ना? Nephrotic syndrome is a hypercoagulable state. Pregnancy is a hypercoagulable state. किसी में भी क्लॉट बन सकता है, डीवीटी में भी थ्रोम्बस बनता है, वैसे इन केसेस में भी थ्रोम्बस बन सकता है। एंड व्हेन द पेशेंट विल स्टार्ट वॉकिंग, then definitely the thrombus will get dislodged, it will go inside the pulmonary vessel and it will block the pulmonary vessels, causing decreased blood supply to the lungs. That leads to respiratory distress in the patient. Here the patient is also collapsed. That means it is a case of massive or submassive pulmonary embolism. It is a case of massive pulmonary embolism. Second reason to call it massive, what did I tell you? ECG and X-ray findings are only seen in massive pulmonary embolism. They are never seen in submassive. Submassive में X-ray और ECG दोनों normal होते हैं, ठीक है? What are these signs which are seen? The first one, the dilated right descending pulmonary artery, known as the Pallas sign. Dilated right descending pulmonary artery, known as the Pallas sign. As blood supply is decreased over here, therefore a triangular opacity or whitish color is seen. That is nothing else but the Hampton-Hump sign. This is the normal Hampton-Hump sign. And तीसरा यहाँ दिख नहीं रहा, focal oligemia, that is decreased blood supply to some part. It is known as Westermarck sign. जो तीसरी sign होती है, that is called as the Westermarck sign. Classical 3 signs of pulmonary embolism on a chest X-ray. And as I've told you, in ECG definitely will get the classical S1, Q3, T3 pattern. Deep S wave in first lead, deep Q wave and deep inverted T wave in third lead. That's the important thing. Now, definitely, what is the screening test for massive pulmonary embolism? First line is the chest X-ray. कर लिया तुमने. ECG भी कर लिया. ठीक है? Now, what is the screening test? D-dimer. Very good. यहाँ पे D-dimer कर चुके हैं. What are the D-dimers? Elevated. याद रखना, D-dimer कब elevated होता है? When the clot or the thrombus breaks. यहाँ पे break हो रहा है, तो definitely the D-dimers are elevated now. Okay, so it is a case of embolism that we know for sure now. ठीक है? Now, what is the investigation of choice? Very good. It is CTPA, that is CT pulmonary angiography. So CT pulmonary angiography is the investigation of choice. If they ask you what is the gold standard investigation, पल्मोनरी एंजियोग्राफी। तुम बोलोगे सर पल्मोनरी एंजियोग्राफी इन्वेस्टिगेशन ऑफ चॉइस क्यों नहीं? बिकॉज इट इज अ इन्वेसिव टेक्निक। ठीक है, प्लीज रिमेंबर इन्वेस्टिगेशन ऑफ चॉइस इज अ सीटी पल्मोनरी एंजियोग्राफी। Thus, gold standard investigation is a pulmonary angiography. Now, important is please remember what is the treatment of choice for massive pulmonary embolism. बताया था मैंने अभी। Catheter directed thrombolysis. Thrombolysis is done with recombinant tissue plasminogen activator. Drugs like वही altiplase, retiplase, tenecteplase. ठीक है? No issues with this. अगर सब massive हो इसमें thrombolysis के साथ साथ I will start low molecular weight heparin in the patient as well. But अगर सब massive होता तो I will have only started लो मोलिकुलर वेट हेपारिन। उसमें थ्रोम्बोलाइसिस नहीं किया जाता। प्लीज रिमेंबर सब में थ्रोम्बोलाइसिस इज contraindicated in submassive pulmonary embolism. That's important. No issues with this anybody? Prevention of further आगे जाके ना हो, प्रिवेंशन या प्रोफाइलैक्सिस के लिए क्या करेंगे? अगर वो पेशेंट में नेफ्रोटिक सिंड्रोम है या वो पेशेंट में डीवीटी है तो हमें पता है कि थ्रोम्बस तो बनेंगे ही बनेंगे, उसके बाद चांसेस है कि वापस पल्मोनरी एम्बोलिज्म भी हो। तो फॉर प्रिवेंशन ऑफ प्रोफाइलैक्सिस आई हैव टोल्ड यू वी कैन प्लेस अ आईवीसी फिल्टर। और सेकंड कैसे करते डीवीटी का फार्माको मैकेनिकल प्रिवेंशन। फार्माको के लिए लो मॉलिक्यूलर वेट हेपारिन देते हो, मैकेनिकल के लिए कंप्रेशन स्टॉकिंग्स या फिर न्यूमेटिक कंप्रेशन स्टॉकिंग जो इलेक्ट्रिकली एक्टिवेट होता है। ठीक है, दैट वाज द प्रीवियस इमेज न्यूमेटिक कंप्रेशन स्टॉकिंग्स वाला। चलो क्वेश्चन सब मैथ्स में एंटीकोएगुलेशन ओनली, लो मॉलिक्यूलर वेट हेपारिन प्लस ओरल वार्फारिन। क्वेश्चन नंबर 180, a 60-year-old woman, 60-year-old pain in the right arm. There is also evidence of ptosis, meiosis, and loss of cerebrospinal reflex on the right side. Okay, chest X-ray has been given below. What is the likely diagnosis? Easiest one. ये क्या बता रहा है सब कुछ? Definitely ptosis, meiosis, loss of cerebrospinal reflex. It is a case of Horner's syndrome definitely. और Horner's syndrome में what is the classical mnemonic? पीस मील या परफेक्ट मील। तो जो भी याद रखना है परफेक्ट मील या पीस मील। ठीक है, तो इंपॉर्टेंट है। परफेक्ट स्टैंड्स फॉर या पी स्टैंड्स फॉर टॉसिस ऑन द अफेक्टेड साइड। ठीक है, देन एम स्टैंड्स फॉर मायोसिस दैट इज कंस्ट्रिक्टेड प्यूपिल। ई स्टैंड्स फॉर एपरेंट, एपरेंट मतलब लगता है नहीं। ओके, संकन आय लगती है तो एपरेंट एनॉफ्थैल्मोस, एनॉफ्थैल्मोस इज संकन आय, तो एपरेंट एनॉफ्थैल्मोस। ए स्टैंड्स फॉर and hydrosis, that is loss of sweating on the affected side, and L stands for loss of cerebrospinal reflex, loss of cerebrospinal reflex। ये very common question है ऑफ्था का या फिर मेडिसिन का। ठीक है, दोनों में से आता है Horner's commonly। Now why there is Horner syndrome in the patient? Due to compression of, very good, due to compression of the sympathetic chain। What are the two muscles which are supplied by the sympathetic nerve in eye? One is the Mueller's muscle, and as Mueller's muscle is paralyzed, therefore the patient is having partial, complete ptosis नहीं होता। Complete ptosis is seen with LPS palsy due to third cranial nerve injury. Partial ptosis is due to the Mueller's muscle paralysis, please remember. And meiosis is due to which muscle is known to dilate the pupil? Dilator pupillae. And dilator pupil is also supplied by the sympathetic nerve. So again, it will be paralyzed. Therefore, the patient has meiosis. Okay, so that's the important thing. No issues with this, anybody? So you can see this meiotic pupil is there. Along with that, there is partial ptosis which is seen. Apparent enophthalmos is there. Loss of sweating will be there, and loss of cerebrospinal reflex. So it is a case of Horner syndrome. Horner syndrome के साथ साथ they have given a history of smoking, and there is also pain in the right arm. Along with that, chest X-ray showing a mass in the right lung, in the superior sulcus. Superior lobe में, upper lobe में mass which is compressing the sympathetic chain. It is nothing else but a Pancoast tumor, also known as the superior sulcus tumor of lung. Previous FMG question, recent 2023 NEET-PG question as well। ठीक है, तो याद रख लो इतना इजी क्वेश्चन NEET-PG में भी आता है, तुम्हारे इसमें भी हार्ड क्वेश्चंस आते हैं, तो दैट्स इंपॉर्टेंट। राइट अपर लोब निमोनिया होता तो डेफिनेटली क्या दिखता? देयर वुड हैव बीन ओपेसिटी इन द राइट अपर लोब। बट निमोनिया होता तो डेफिनेटली the patient would have given history of what? Fever, cough and tachypnea. Tachypnea is rapid respiratory rate, तो उसकी हिस्ट्री होती, ठीक है? So that's important. No issues with this, anybody? Aspergilloma is commonly seen in a patient of either COPD or in a case of bronchial asthma usually. It is due to Aspergillus fumigatus that leads to collection of a fungal hyphae forming a ball, and that ball is known as aspergilloma. ठीक है? Question number 181. A patient presents to the emergency room with complaints of headache, fever, and projectile vomiting. On examination, neck stiffness is noted. So headache, fever, and neck stiffness. Classical triad of meningitis. Any which ways उन्होंने meningitis ही पूछा है बस. ठीक है? Kernig sign is also elicited. Lumbar puncture is done. Lumbar puncture analysis reveals mononuclear cytosis. Now ये खेल जाते हैं वो. कभी-कभी वो लिखते हैं polymorphonuclear cells. अब उसका आंसर बताओ मुझे. Polymorphonuclear cells का मतलब शाबाश, neutrophils. So in the previous exams they have written polymorphonuclear cells are seen. अब लोगों को यही नहीं पता ये पॉलीमॉर्फोन्यूक्लियर सेल्स क्या बला होती है. तो पॉलीमॉर्फोन्यूक्लियर सेल्स मतलब जिसके न्यूक्लियस में 3 से 5 लोब होते हैं, दैट्स बस न्यूट्रोफिल ही होता है. ठीक है? तो पॉलीमॉर्फोन्यूक्लियर सेल्स आर न्यूट्रोफिल्स. अगर पीएमएन बोला गया है, दैट इज अ बैक्टीरियल मेनिंजाइटिस. बट as they are saying mononuclear cytosis, we know lymphocytes only have a single large nucleus, so these can be called as mononuclear cells. So they are talking about which cells? They are talking about lymphocytes. So which one is ruled out? Bacterial and meningitis is directly ruled out definitely. ठीक है? Pyogenic meningitis. Next, moderately low sugar is there. If there is low sugar, okay, definitely which one is ruled out? Viral meningitis is ruled out directly. ठीक है? Now, definitely elevated protein levels in see all of them. What is the likely etiology? What is this, anybody? Fibrinous exudate causing a cobweb coagulum. So cobweb coagulum with decreased blood sugar levels, CSF sugar levels along with lymphocytosis is definitely a feature of tubercular meningitis. Aseptic meningitis क्यों बोला जाता है? Because aseptic meningitis में the cells are not increased. Okay, the cells are not predominantly increased. Mild elevation दिखता है. Okay, aseptic meningitis is usually seen in cases of, it is a complication, most common complication of which infection? Aseptic meningitis is the most common complication of which infection? Mumps. Very good. Please remember, most common complication of mumps is aseptic meningitis. In children also it is aseptic meningitis. In adolescent males it is orchitis, and in adolescent females it is ophoritis. So orchitis nahi mark karna hai. If they ask you most common complication of mumps, it is aseptic meningitis. Okay. Question number 182. A patient was diagnosed with cirrhosis and assessed on a Child-Pugh score for severity of disease. So if you need to assess the severity of liver disease or to assess the severity of cirrhosis or to see whether the patient needs a liver transplant or not, for that we have two important scores. And what are those? One is called as the Child-Pugh score and second is called as the MELD score. MELD score is nothing but the model for end stage liver disease. दोनों स्कोर का पता होना इंपॉर्टेंट बिकॉज बोथ ऑफ देम हैव बीन आस्क्ड इन योर एग्जामिनेशन प्रायर. ज्यादा कोई नहीं, डिस्क्रिमिनेंट स्कोर वगैरह नहीं याद रखोगे, दैट्स फाइन. दीस टू आर इंपॉर्टेंट. नाउ ऑल ऑफ द फॉलोइंग पैरामीटर्स आर इंक्लूडेड इन द स्कोर एक्सेप्ट Child-Pugh स्कोर. मनी सर वुड हैव गिवन द निमोनिक. क्या निमोनिक दिया सर ने? चाइल्ड को क्या बोलते हैं? बेटा. तो डेफिनेटली Child-Pugh स्कोर का निमोनिक इज बेटा. सो बी स्टैंड्स फॉर सीरम बिलिरुबिन लेवल्स. हाई और लो? Cirrhosis है तो definitely high ना, so serum bilirubin levels will be high. Now if there is excessive bilirubin inside the body, it will damage the brain. That is called as encephalopathy. Okay, so please remember, E stands for encephalopathy. T stands for liver is damaged. We know liver is the factory which produces clotting factors. तो clotting factors बनेंगे क्या अगर cirrhosis है? नहीं बनेंगे. और अगर नहीं बनते तो prothrombin time will be prolonged, INR will be prolonged. So T stands for time. Which times usually? PT or INR. It will be prolonged. Then A stands for, as the brain is damaged, we will have flapping tremors, and these flapping tremors are called as asterixis. So definitely there will be asterixis in the patient. And not only the clotting factors are not formed, no proteins are formed by the liver. And definitely if proteins are not formed by the liver, which pressure will decrease inside the vessel? Plasma oncotic pressure. This pressure is not there, so fluid will go outside, causing edema and ascites. So increased bilirubin, encephalopathy, PTINR, asterixis, and ascites are the classical features of Child-Pugh score, which will tell you about the severity of liver disease or the need plantation. So definitely bilirubin, asterixis, PTINR is there. Serum creatinine is not used in Child-Pugh score. Med score में the mnemonic is CBI. So C stands for serum creatinine. It will also tell you about concomitant or simultaneous renal failure in the patient as well. B stands for serum bilirubin, which will be increased, and I stands for PTINR usually. Okay, no issues with this. That's important. Chalo. Question number 183. A 32-year-old alcoholic male was brought to the hospital when he fainted down after an episode of binge drinking. His friends gave history of excessive retching episodes and chest pain. His vitals are blood pressure is 88 by 60 millimeters of mercury. Pulse rate is 125 beats per minute. Blood pressure is low, that is hypotension. Pulse rate is high, that is tachycardia. Both are suggestive together of shock in the patient. Respiratory rate is high, that is 28 breaths per minute. That means he's also having some respiratory difficulty. Chest X-ray has been given below. What is the probable diagnosis? What is seen on the chest X-ray? Air is seen below the, very good. Air is seen below the cardiac shadow known as the continuous diaphragm sign. And what did I tell you in surgery? Continuous diaphragm sign is a feature of, अरे बोर हैव डायरेक्टली थोड़ी होता है. Continuous diaphragm sign बताता क्या है बस तुम्हें? Pneumomediastinum. That means there is air inside the mediastinum. Okay, so any cause can be there, na? It can be tracheal rupture also. उसमें भी pneumomediastinum हो सकता है. So please remember, pneumomediastinum बताता है continuous diaphragm sign. Okay, please remember that. Now definitely the patient is having pneumomediastinum. That means air has gone inside the mediastinum. इसका मतलब air कहाँ से जा सकती है? Either the esophagus is ruptured or the trachea is ruptured. ठीक है? Usually. So definitely now, as they are saying that there is a history, he's a chronic alcoholic male and he has a history of binge drinking. अब तुम्हारा दोस्त जो पार्टी नहीं दे रहा था फ्री में दे दी, तुमने 3 की जगह 10 बियर पी ली, ठीक है, और उसके बाद 4 प्लेट बिरयानी खा ली. तो अब बिंज ड्रिंकिंग, बिंज ईटिंग, उसके बाद तुम्हें क्या हो गया? फिर उल्टी. वो मन में गाली दे रहा था, साले को पचेगा नहीं, तो फिर डेफिनेटली तुम्हें क्या हो गई? उल्टियां. तो रेचिंग एंड वॉमिटिंग एपिसोड्स विल बी देयर. Now, if due to that retching or vomiting episode, there will be excessive stress on the esophagus, and due to that, the esophagus has ruptured, and therefore all the food, all the contents of the esophagus will go inside the mediastinum. What did I tell? Mediastinum is a sterile cavity. Will it handle any nuisance? No. It will immediately get inflamed. That is mediastinitis. That causes severe chest pain, which will look like MI. Apart from that, air will also go outside. That causes pneumomediastinum, which leads to continuous diaphragm sign, and air will also go beneath the skin called the subcutaneous emphysema. So chest pain, retching or vomiting episode along with subcutaneous emphysema. कौन सा triad है ये? Very good. It is the classical macular triad. Okay, it is known as the macular triad, and macular triad is seen in cases of Boerhaave syndrome, which is a spontaneous esophageal perforation or a rupture of the esophagus. अगर चलो जिन्होंने ए मार्क किया है, तुम ही बताओ मुझे. अब सबसे इंपॉर्टेंट, इसमें भी अल्कोहलिक पेशेंट होगा, ठीक है, और अगर किसी ने रेगुलर बैच वालों ने या फिर टीएनडी वालों ने अगर मार्क किया होगा मैलेरिवियस, तो मुझे क्लास के बाद आके मिलना, मैं बताता हूँ. मैंने इस पे 1 घंटा बर्बाद किया सर्जरी पढ़ाते पढ़ाते, ठीक है. तो इंपॉर्टेंट है, मैंने तीनों का डिफरेंस बताया था. ब्लीडिंग एसोफेजियल वेराइसिस, बोरहाव सिंड्रोम, मैलेरिवियस कैसे प्रेजेंट करेगा पेशेंट, ठीक है. तो प्लीज रिमेंबर, इफ देयर इज अ अल्कोहलिक मेल हु हैज प्रेजेंटेड विद रेचिंग और वॉमिटिंग एपिसोड, ठीक है, रेचिंग और वॉमिटिंग एपिसोड, प्लीज रिमेंबर, आफ्टर व्हिच द पेशेंट इज हैविंग अपर जीआई ब्लीड. अपर जीआई ब्लीड प्रेजेंट्स एट हेमाटोइमेसिस. बस नो चेस्ट पेन, यूजुअली नो चेस्ट पेन, वेरी माइल्ड अगर होता भी है तो. नो सबक्यूटेनियस एम्फाइसीमा, नो न्यूमोमिडियास्टिनम, नो कंटिन्यूअस डायफ्राम साइन, नथिंग, ओनली हेमाटोइमेसिस. That is a case of malarious tear. Okay, which is a tear, it is a partial mucosal or submucosal tear in the esophagus, which starts from the gastroesophageal junction and proceeds upwards, and that causes upper GI bleed in the patient. Please remember, most common artery to bleed, left gastric artery. Please remember, it is the left gastric artery. It is also the most common artery to bleed in gastric ulcer. Gastric ulcer. क्यों पता है? Peptic ulcer is gastric and duodenal as well. More common of which one? Duodenal. So in duodenal ulcer, it is not the left gastric artery which bleeds. It is the Duodenal artery. That was a previous year question. Most common artery to bleed in peptic ulcer. Answer is gastroduodenal artery. No issues with this, anybody? That's important. So that is the case of malarious. Investigation of choice will be upper GI endoscopy, and treatment will be no treatment, self-limiting condition in malarious tear. Please remember, if the patient has a lot of bleeding or control nahi ho pa raha, then we'll go for angioembolization. Otherwise, it is self-limiting condition itself. ठीक है? Four halves में जल्दी से बताओ चलो. Investigation of choice. First line is chest X-ray. Investigation of choice is a CT with a water-soluble contrast. It will go inside the mediastinum. तुम्हें पता लगेगा rupture है. ठीक है? And what is the treatment? अब infection है पूरे mediastinum में. खोलना पड़ेगा ना, तो खोलोगे, थोरैक्स को खोलते हो तो उसको क्या बोलोगे? थोरैकोटोमी. क्लीन करना पड़ेगा मीडियास्टिनम, तो मीडियास्टिनल लवाज. And with or without closure. You, if the patient presents to you early, minimal contamination, go for immediate closure. If the patient presents to you late, बहुत ज्यादा contamination, sutures cannot be held together, leave a drain, wait for some time, go for closure after some time. ठीक है? When the infection subsides. No issues with this, anybody? That's important. So this is not there. Stomach volvulus या gastric volvulus में triad. मुझे लगा था ये बताने की जरूरत नहीं पड़ेगी, सर्जरी और ENT की चीज है. ये उल्टा ज्यादा बताने की जरूरत पड़ रही है. Sigmoid volvulus में दिखता है वो. Coffee bean sign और bird beak appearance. Coffee bean sign on plain abdominal X-ray. Bird beak appearance on barium enema. Volvulus is what? Twisting ना, malrotation of the stomach. कौन सा triad दिखता है? Borcher's triad. Borcher's triad क्या होता है? Upper abdominal pain or epigastric pain, along with vomiting episodes, along with inability to pass the nasogastric tube. That is the classical Borcher's triad seen in gastric or stomach volvulus. भाइयों सर्जरी पढ़ लेना एक बार. ठीक है? Question number 184. A person presented to the OPD with complaints of abdominal pain and brownish black melanotic spots as shown in the image. Colonoscopy revealed multiple polyps. Biopsy was suggestive of hematomatous origin. Which is the most likely gene mutation? Provisional diagnosis. It is a case of Peutz-Jeghers syndrome. What are the two features in a case of Peutz-Jeghers syndrome? One, there will be multiple. Which kind of polyps? Hematomatous polyps. Most common site will be jejunum. It will be jejunum. And second feature will be the brownish blackish melanotic spots which are seen around the oral cavity. That is the characteristic feature of Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is due to which gene mutation? STK11 chromosome 19. ठीक है? STK11 gene mutation. Sorry. MSH2 or MLH1 gene mutation causes which DNA repair defect? MSH2 or MLH1? कल ही बताया मैंने. MSH2 or MLH1 gene mutation causes mismatch repair gene defect, and mismatch repair gene defect is associated with Lynch. Very good. HNPCC, that is hereditary non-polyposis colon cancer, also known as the Lynch syndrome. Please remember this. APC gene mutation is associated with chromosome number 5, associated with FAP, familial adenomatous polyposis. डॉक्टर तरुण, डॉक्टर मनीष, मैं 3 बार ये रिपीट हुआ होगा FAP. अब तक याद नहीं हुआ है. ठीक है? More than 100 adenomatous polyps in the intestine and 100% risk of malignancy. Therefore, we will go for prophylactic total proctocolectomy in the patient. Please remember, c-KIT gene mutation, GIST, okay? And GIST is gastrointestinal stromal tumor, arises from which cells? Interstitial cells of Cajal, the pacemaker cells of GIT. Important. What is the best tumor marker? DOG1. Second best is CD117. Please remember. Okay? Second best is CD117. No issues with this, anybody? Management is surgical resection. But if it is metastatic GIST or a recurrent GIST, then the drug of choice is imatinib. Okay? So this is a case of FAP, more than 100 adenomatous polyps. Question number 185. A 36-year-old female presented to the medicine OPD with complaints of blanching of her toes on immersion in cold water. ये क्या होता है? Blanching मतलब white. ये जो दिख रहा है ना, अब blanching होती है. White appearance जो दिखता है. So blanching of her toes on immersion in cold water. They are talking about which phenomena? Raynaud's phenomena. Okay? Along with that, they are saying she is also having difficulty in swallowing food. That is dysphagia. It is due to esophageal dysmotility. She gives history of skin tightening in the patient, and there is shortness of breath. Matlab lungs are also involved. What is the most probable diagnosis? Aram. C stands for calcinosis cutis. That is, the patient will only have chalky plaques inside the skin. Skin tightening is not a feature of Crest syndrome. There is only calcification of skin, okay, in some parts, chalky plaques. R stands for Raynaud's phenomena. E stands for esophageal dysmotility. ये दिया हुआ है, ठीक है, okay? Important. S stands for sclerodactyly. That is pitting of fingers. यहाँ pitting होती है ना? That is sclerodactyly. And T stands for telangiectasia. That is Crest syndrome, also known as limited scleroderma. So why it is called as limited? Because it is only limited to the specific organs. It does not spread outside that organ. If there is the involvement of many organs of your body, mainly the lungs, then it has to be a case of systemic sclerosis. That is nothing else but scleroderma. It has to be a case of systemic sclerosis or to be a case of scleroderma. Which antibodies are the investigation of choice? Anti-topoisomerase. Whereas Crest syndrome के लिए anti-centromere antibodies. Please remember, ये image, ऐसी similar image तुम्हारे एग्जाम में आई थी, and they mentioned skin tightening. A lot of people marked it as different. पता नहीं किसी ने SLE mark कर दिया, किसी ने RA mark कर दिया. Please remember, skin tightening usually, okay, is a classical feature, or leathery appearance of skin also sometimes they can mention. It is a classical feature of स्क्लेरोडर्मा. क्यों? क्योंकि स्क्लेरो मतलब ही क्या होता है? स्क्लेरोसिस या फाइब्रोसिस. किसका? डर्मा मतलब स्किन का. So there is fibrosis or sclerosis of skin, due to which the skin becomes tight, or there is a classical leathery appearance of skin. The skin can also become shiny like this. Okay? No issues with this, anybody? That's important. Sarcoidosis, सरकारी क्वेश्चन एग्जाम का तुम्हारे, हर एग्जाम में रादर. क्या होता है? क्लासिकल फीचर्स कैसे पहचानोगे? वेरी गुड. So please remember, classical feature, ये जैसे ही मेंशन होगा या मुझे ये एक्सरे मिलेगा, I will mark it as sarcoidosis. Middle aged female having shortness of breath or respiratory distress with classical bilateral hilar lymphadenopathy. दोनों साइड के हाइलम में lymphadenopathy दिख रही है. Along with that, this purplish color region, यहाँ भी हो सकता है वो, involving the nasolabial folds. SLE में जो मलार रैश होता है, it never involves the nasolabial folds. It can involve nasolabial. ये कौन सा? Lupus pernio, which is a characteristic skin lesion seen in cases of sarcoidosis. Important, sarcoidosis causes multiple cranial nerve involvement also. The most common cranial nerve involved is facial nerve. Rather, recent NEET-PG 2022 question, they gave a classical case of sarcoidosis and they asked, okay, there was also features of bilateral facial nerve palsy, and they asked, what is the cause? Answer was sarcoidosis. ठीक है, bilateral hilar lymphadenopathy भी mention थी, and bilateral facial palsy भी mention थी. ठीक है, so it can also lead to bilateral facial palsy in a patient as well. No issues with this, anybody? Drug of choice, sarcoidosis, autoimmune condition है ना? Steroids, please remember. And there will be increased levels of two things, vitamin D and ACE enzyme. ये इंपॉर्टेंट है अगेन डायग्नोसिस के लिए. विटामिन डी एंड एस एंजाइम की लेवल्स बढ़ी हुई होगी. इफ आई टेक अ लिम्फ नोड बायोप्सी, बायोप्सी पे क्या दिखेगा मुझे? किस टाइप का ग्रैन्युलोमा? केजेटिंग, नॉन केजेटिंग? वेरी गुड, नॉन केजेटिंग ग्रैन्युलोमा. मैंने बोला था दो चीजों पे नॉन केजेटिंग ग्रैन्युलोमा याद रखना है. वन इज सार्कोइडोसिस, सेकंड इज क्रोन्स डिसीज. केजेटिंग ग्रैन्युलोमा कहाँ का याद रखना है? ट्यूबरकुलोसिस, सिफिलिस, देन हिस्टोप्लाज्मोसिस एंड coccidioidomycosis. Two fungal infection, okay, याद रखना है. Two bacterial infection. कोई दिक्कत नहीं है. Question number 186. A 56-year-old hypertensive patient with history of DVT comes to OPD with complaints of recurrent episodes of retrosternal chest pain lasting for about 5 minutes, and it is relieved on rest. Okay, ECG appears to be normal and trop T is negative. Which among the following is the next step? So is it a case of MI or angina? It is a case of chest pain. That means it is a case of angina pectoris. Angina pectoris can be of three types. But it can be a case of classical angina, then it can be a case of Prince metal angina. Prince metal angina is also called as variant angina or vasospastic angina. And the third type of angina is unstable angina. Basic difference between classical and unstable angina. Classical angina का patient आता है OPD में, unstable angina का patient आता है emergency में. पहला difference. Next, classical angina के patient में chest pain is relieved by rest, but in cases of unstable angina, chest pain is not relieved by rest. Chest pain is relieved by nitroglycerin, that is drug intake. ठीक है? In cases of classical angina, pain is short lasting, but in case of unstable angina, the pain is long lasting, and the pain can mimic MI. That means it can radiate to left shoulder, back as well in unstable angina. ठीक है? No issues with this, anybody? That's important. Whereas prinzmetal angina में there is a early morning pain. Okay, there is a classical early morning chest pain due to vasospasm of the coronary arteries. Please remember that. No issues with this, anybody? Important. ECG अगर मैं करूंगा तो in cases of classical angina, usually during the episode I might see some changes, but if the patient comes in between the episode, ECG will be absolutely normal. ECG will be absolutely normal in between the episodes. During episode I might see some changes. Unstable angina में I will be able to see ST segment elevation or depression. Definitely, because please remember, episode के दौरान यहाँ भी ST segment depression दिखता है, and in unstable angina always we see usually a ST segment depression. 50% cases normal भी होता है. 50% cases of unstable angina can show normal ECG. 25% will show ST segment depression. ठीक है? And 25% will show T wave inversion. These are signs on ECG for myocardial ischemia. That means there is decreased blood supply to your myocardium. Only angina with ST segment elevation is prinzmetal angina. ये होता है differential. जैसे ही वो बस angina बोलते हैं, or definitely the ECG showing ST elevation, diagnosis can be prinzmetal or vasospastic angina. That's how easy it is. Trop, that is cardiac biomarkers. Troponins. Troponin I is best, followed by troponin T. ठीक है? So troponins or any other cardiac biomarkers will be normal or elevated in cases of angina. They will be normal usually in cases of angina. In cases of unstable angina, they might be mildly elevated. They can be mildly elevated. That's it. ठीक है? Mild बोल रहा हूं मैं again. Myocardial infarction में cardiac biomarkers या troponins are 10 times elevated. ठीक है? ये diagnostic criteria होता है. 10 times elevated होता है उसमें. No issues with this. So here it is a case of angina definitely in a patient. और कौन सा angina है? Recurrent episodes है. Chest pain lasting for 5 minutes and relieved on rest. So it is a case of classical angina or it is a chronic stable angina. Okay, you can also call it as a stable angina. Chronic stable angina. ECG appears to be normal. We know. Trop T is negative. Okay, what is the next step? हमें क्या पता है कि ECG will only show changes during a episode. So we can precipitate an episode of angina. How we can precipitate an episode of angina? By causing stress in the patient. Definitely. क्या कर सकते हैं हम? उसको ज्यादा भगा सकते हैं so that his demand of the myocardium increases, and as there is blockage in the artery, will the artery be able to supply the increased demand? No. Due to that the patient experiences pain. Unstable में क्या हो जाता है? The blockage is too much. Now even the patient is having pain at rest. That is seen in unstable. Stable or unstable में difference समझ लो. Stable में there is only 70% blockage. Therefore, the patient has pain only on exertion. But in unstable, the blockage is almost around 90-95%. Therefore, the patient has pain even on rest. That's the basic difference. ठीक है? याद रखो ये बात. So definitely we will precipitate an angina by stress. So usually we can perform a stress treadmill test, but usually they have given a case of DVT. अगर तुम इसको भगाओगे treadmill पे इस patient में, first line is always treadmill test. But some conditions where treadmill test cannot be done will be a case of DVT. क्यों? अगर तुम इसको DVT के patient को भगा रहे हो, the thrombus can get dislodged and it can cause pulmonary embolism. It can even lead to cerebral embolism in the patient. Will you take that chance? No. So therefore, stress treadmill test will not be there. If stress treadmill test cannot be done, therefore the best one will be stress echocardiography. That means without उसको भगाए तुम उसका heart की demand increase करते हो. कैसे? By increasing the heart rate. And what is that drug that we give in stress echocardiography? IV dobutamine. It acts on which beta receptors? Beta 1 receptor. It is a beta 1 agonist. Therefore, it causes increased heart rate. No issues with this, anybody? What is the treatment in cases of stable angina? Chronic stable angina में क्या देते हो? Chronic stable angina. Drug of choices IV nitro. The drug of choice is nitroglycerin usually. Drug of choice for Prinzmetal angina, nitroglycerin drip. Okay, again for Prinzmetal angina also the single best drug of choice is nitroglycerin drip. But in cases of chronic stable angina, they ask the drug of choice overall. ये emergency में देते हो भाई. Again you will get emergency in chronic stable angina. We will treat the patient by nitroglycerin. But overall drug of choice क्या होना चाहिए? Very good. Decrease the demand of the heart, na? Decrease the demand of the heart by decreasing the heart rate. And therefore, the drug of choice for chronic stable angina, which will decrease the heart rate, are beta blockers. Non-selective or cardioselective? Cardioselective. Drugs like metoprolol. So, drug of choice for chronic stable angina are selective beta 1 blockers like metoprolol. Please remember, whereas in cases of emergency, you can give IV metoprolol along with nitroglycerin as well. No issues with this. Unstable angina. Please remember, unstable angina looks like non-ST elevated MI. How to differentiate? क्योंकि दोनों में ST segment का क्या दिखेगा? Depression. We will do cardiac biomarkers, that is TROPs. TROP will be highly elevated in NST-MI. They will be normal or slightly elevated in unstable angina. Treatment for both of them is same, that is Abemona. So Abemona, A stands for AB6C MAB, antiplatelet drug. B stands for cardioselective beta blocker, that is metoprolol. E stands for heparin analog, that is enoxaparin. M stands for pain relief के लिए morphine. O stands for oxygen. N stands for nitroglycerin. A stands for dual antiplatelet therapy, because we will not only give aspirin, we will also give clopidogrel. That is called as a loading dose of MI. ठीक है, बस एस्पिरिन नहीं देते हो, क्लोपिडोग्रेल भी देते हो सर. और स्टेमाई में तो पता ही होगा, स्टेमाई में इट इज ओनली सोनम, दैट इज स्ट्रेप्टोकाइनेज. यूजुअली दैट मींस थ्रोम्बोलाइसिस. आजकल स्ट्रेप्टोकाइनेज यूज नहीं करते, वी यूज एल्टीप्लेज रेटिप्लेज. बट एस फॉर स्ट्रेप्टोकाइनेज दैट इज थ्रोम्बोलाइसिस. O फॉर ऑक्सीजन, N फॉर नाइट्रोग्लिसरीन, E फॉर antiplatelet therapy, both of them, and M for morphine. कोई दिक्कत नहीं है इसमें. Question number 187. A patient was having, जल्दी से ये बता दो बस, which is the best cardiac biomarkers in MI? Troponin. Troponin I or T? I, followed by T. Which is the earliest cardiac biomarker to rise? Very good. Heart fatty acid binding protein, followed by myoglobin. पहले लास्ट एडिशन ऑफ हैरिसन में अपडेट हो चुका है, ठीक है. तो अब मायोग्लोबिन बदल दो भाई, ठीक है. इट इज हार्ट फैटी एसिड बाइंडिंग प्रोटीन. रॉबिन्स हैज आल्सो चेंज्ड इट, ठीक है. तो हार्ट फैटी एसिड बाइंडिंग प्रोटीन फॉलोड बाय मायोग्लोबिन, ठीक है. व्हिच इज द मार्कर ऑफ रीइंफाक्शन? वेरी गुड. CKMB can be used within 72 hours, but now Robin says, recent update hai, now Robin says even within 72 hours, after 72 hours, the best cardiac biomarker is TROP-I itself. कैसे तुम बोलोगे सर वो ऑलरेडी एलिवेटेड है? 20% इंक्रीज फ्रॉम द बेसलाइन, जितना था उससे 20% अगर बढ़ गया है, दैट इज अ केस ऑफ रीइंफाक्शन, ठीक है. क्या इमरजेंसी में जो हम ब्लड निकालते हैं ना और जो किट पे करते हैं, दैट इज ट्रॉप-टी. ट्रॉप-आई बेस्ट मोस्ट कॉमन ट्रॉप-टी. मैं वही तो बोल रहा हूँ, जो किट होती है ना तो उसमें ट्रॉप-टी देखा जाता है. ट्रॉप-आई जो होता है ना वो ब्लड सैंपल जब लैब में भेजेंगे तभी देख सकते हो. किट नहीं है ट्रॉप-आई के लिए कोई भी. किट इज ओनली फॉर ट्रॉप-टी, ठीक है. So that's important. Question number 187. A patient having chronic liver disease presented to the OPD with fever, tachypnea, that is increased respiratory rate, and gross abdominal distension. Abdominal distension is suggestive of ascites likely, क्योंकि it is a patient of cirrhosis of chronic liver disease. So most likely, if there is abdominal distension, they are talking about ascites in a patient of CLD. On abdominal examination, there is tenderness, which is elicited. Normally, ascites is painful or painless? Painless. कितना भी पेट बड़ा हो कोई दिक्कत नहीं होती, ठीक है. So it is painless. But here there is tenderness now. That means it has become painful. Along with that, there is fever. Okay, along with that, there is tachypnea. These signs are suggestive that there might be infection or inflammation along with ascites. Okay? So ascitic fluid also reveals ascitic tap kara. On that, we can see 500 neutrophils. That is confirmatory that there is an infection. And this is a case of kaha infection hai, ascites fluid kaha jama hua hai? Peritoneum. And agar infection of peritoneum is called as peritonitis. But this is a case of spontaneous bacterial peritonitis. This is a case of spontaneous bacterial peritonitis. What is the next best step in the management? Definitely, as it is a case of spontaneous bacterial peritonitis, the drug of choice should be option B, antibiotic, that is IV, C4-taxib. Please remember that. Okay? Sir, H is then. Yeah, it is early also and it is sensitive as well. Okay? Important. This question has been repeated thrice in the FMG exam. Thrice in the FMG exam. और मैं बोल दो कौन से क्वेश्चन रिपीट होते हैं जो बार बार बच्चे गलत मार्क करते हैं. तो ये क्वेश्चन हर बार पढ़ाते हैं तो भी आके गलत मार्क करके आते हैं. तो इसीलिए ये क्वेश्चन बहुत बार रिपीट हो रहा है. यूजुअली नाउ यू वोंट मार्क रॉन्ग, तो देयरफॉर मोस्ट लाइकली अब से आना बंद हो जाता है. नाउ इफ दे से देयर इज ओनली अ पेशेंट ऑफ ascites, spontaneous bacterial peritonitis नहीं था, then your answer would have been very good. Only a case of ascites, your answer should have been large volume paracentesis. But अगर तुम large volume ascitic fluid निकाल रहे हो, paracentesis कर रहे हो, तो पेशेंट में क्या हो जाएगा? अचानक से हाइपोटेंशन में जाएगा ना पेशेंट अचानक से, राइट? तो क्यों जाएगा? क्योंकि ऑलरेडी उसके बॉडी में एल्ब्यूमिन नहीं है. तुम ये निकाल रहे हो एसिडिक फ्लूइड, तो जितना तुम निकाल रहे हो उतना वो और आते जा रहा है ब्लड वेसल से. तो ब्लड वेसल में कोई ना कोई ऐसी कुछ चीज दे दो जो फ्लूइड को अंदर रोक के रखेगा. व्हाट इज दैट चीज? Albumin, colloids, right? Albumin, that is salt-free albumin. So before a large volume paracentesis, always give salt-free albumin to a patient. Otherwise, please remember, your patient will land up into hypotension. Ascitic tap बहुत बार interns करते हैं, ठीक है? तो ask, तुम्हें नहीं बोलेंगे लिखने के लिए, लिखा होगा पीजी ने वगैरह, बट एक बार पूछ लेना. अगर तुम लार्ज वॉल्यूम निकालने वाले हो तो पहले एक बार पूछ लेना सिस्टर को कि सिस्टर एल्ब्यूमिन चढ़ाया उसको. अगर सॉल्ट फ्री एल्ब्यूमिन चढ़ाया हो तभी जाके आधे घंटे बाद तुम ascitic टैप कर लेना या लार्ज वॉल्यूम पैरासिंथेसिस कर लेना. अगर तुम डायरेक्टली करोगे विदाउट, प्लीज रिमेंबर वो तुम टैप तो कर रहे हो बट वो फ्लूइड आते ही जा रहा है बाहर, आते ही जा रहा है बाहर, आते, तो वो कहां से आ रहा है? वो ब्लड वेसल से आ रहा है फ्लूइड बाहर, एंड ही विल गो इनटू हाइपोवोलेमिक शॉक. ठीक है, तो दैट्स इंपॉर्टेंट. और तुम्हें कुछ नहीं होगा, इंटर्न्स को कोई दिक्कत नहीं होती. योर पीजी वुड बी सूड. ठीक है, सो दैट्स द इंपॉर्टेंट थिंग. तो याद रखना, गलतियां करनी भी हो तो इंटर्नशिप में कर लेना. गाली खाएगा तो वो खाएगा, तुम नहीं खाते. ठीक है, सो दैट्स इंपॉर्टेंट. क्वेश्चन नंबर 188 हम भुगत चुके हैं. चलो आगे दे. चलो क्वेश्चन नंबर 188. 56-year-old obese man, known hypertensive, presents with diffuse chest pain at rest, which radiates to the left shoulder. Okay, so usually there is diffuse chest pain at rest. Either it can be a case of unstable angina or it can be a case of MI, myocardial infarction. Okay, he gives history of admission few weeks ago for a recent MI. उसको पहले MI हो चुका है. That means this can be a case of MI again. ठीक है. On auscultation, pericardial friction rub is heard and the ECG taken is given below. ठीक है. What will be the preferred treatment? तो पहले ECG बताओ मुझे. चलो, pericardial friction rub is suggestive of pericarditis in a patient. ठीक है. How to differentiate between a pericardial friction rub and a pleural rub? Pleuritis और pericarditis में differentiate कर करोगे. Very good. Agar if you ask the patient to stop breathing and the rub stops, it is a case of pleural rub. And even if the patient has stopped the breathing, still also if the sound continues, then it is called as a pericardial rub. ठीक है, तो breathing stop होती है, sound stop होता है, pleural rub. Breathing stop होती है, sound चलता रहता है, pericardial rub. That's the basic difference. ECG क्या दिखा रहा है बताओ. चलो, ST elevation दिखा रहा है, right? 1, 2, okay, V1, V2, V3, almost all reads, V5, V6, V7, V6. Every lead is showing ST elevation. और ST elevation कैसा है? कॉनकेव या कॉन्वेक्स है? कॉनकेव या कॉन्वेक्स है? Concave upwards. Okay, so it is concave upwards. So ST elevation, please remember, ST elevation which is concave upwards is a characteristic feature of MI or acute pericarditis. It's a classical feature of acute pericarditis. There will be concavity in the ST variation in all the leads, almost all the leads except the AVF. Okay, please remember. And important is if they say that the ST elevation which is there now, it is convex upwards. This is called as which sign? This is known as which sign by Pardee sign or which appearance? Tombstone appearance, and that is a feature seen with STEMI, ST elevated MI. Please remember, got it? तो ST elevation pericarditis में भी होता है और MI में भी होता है. How to differentiate? If it is concave upwards, okay, that means like this. If it is concave upwards, it is a case of pericarditis. But if it is convex upwards, like bull's hump, then it is a case of STEMI. That is how you differentiate it. Okay. So now usually this patient has developed acute pericarditis after an episode of MI. क्या बोलते हैं इस condition को? Shabash. It is a case of Dressler syndrome. Acute pericarditis developing after a myocardial infarction. Case of Dressler syndrome, previous year FMG question. Okay? So, what is the treatment in this patient? Most common cause of acute pericarditis is idiopathic. Sometimes it can be viral infection. Sometimes it can be a bacterial infection like rheumatic heart disease. Sometimes it can be fibrinous only. Okay? Sometimes it can be tubercular as well. Sometimes it can be uremic. Uremic कब होता है? When there is kidney failure. Due to kidney failure, urea is collected inside the body. All that urea and ammonia will collect inside the pericardium, and that can lead to uremic pericarditis. Okay, so that's important. Now here it is a post-MI, so therefore it is called as Dressler's syndrome. It is nothing, it is due to inflammation itself. Okay, following MI, there can be inflammation that causes this, and therefore the treatment will be aspirin. Aspirin is the drug of choice for Dressler's syndrome. Okay, pericarditis, which is following rheumatic heart disease. Pericarditis following rheumatic heart disease. I hope all of you are quite aware. Rheumatic heart disease ka criteria for diagnosis is known as modified Jones criteria. J stands for joint involvement. Okay, that is arthralgia or arthritis. India mein polyarthritis या monoarthralgia. Even monoarthralgia can also be diagnostic. Reason is we are high endemic country. ठीक है तो इसलिए. Next, O stands for O से heart याद रख लो. तो it is carditis definitely. Pancarditis, endomyopericarditis. Most common type of carditis will be pericarditis. And which type of carditis? Fibrinous pericarditis, known as bread and butter pericarditis in RSD. ठीक है. N stands for subcutaneous nodules. E stands for erythema marginatum. S stands for Sydenham's chorea. ठीक है. Sydenham's chorea is a late feature. What is the earliest feature? Arthritis is the earliest feature. ठीक है. No issues with this anybody. Heart, ये देखो कार्डियो से जिसको दिक्कत आ रही है, आई एम गिविंग important topics. Cardiomyopathy, rheumatic heart disease, sorry, infective endocarditis, myocardial infarction. कम से कम हार्ट साउंड्स मर्मर्स में नहीं घुसना ना, मत घुसो. Nobody is asking you to go over there. At least these 4 topics. ठीक है. बाकी मैंने कार्डियक टेम्पोनेट सर्जरी में कवर किया हुआ है. ठीक है. So you don't need to worry about that. At least these 4 topics are very very important. इसी में से क्वेश्चन आता है, मैं गारंटी देता हूँ. ठीक है. तो प्लीज रिमेंबर, डोंट वरी. कुछ क्वेश्चंस हार्ट साउंड मर्मर्स में से आएंगे, बट वो 1-2 क्वेश्चन छूट भी जाए कोई दिक्कत नहीं, क्योंकि उसमें पीछे दिमाग खराब करोगे, ये 4 टॉपिक्स हाथ छोड़ दोगे तुम लोग. तो दैट शुड नॉट बी डन. ठीक है. तो बी स्मार्ट इन स्टडीज. नाउ यू हैव लेस टाइम ना, तो फोकस ऑन एक्चुअली द हाई यील्ड एंड द इजी टॉपिक्स. दैट शुड बी डन. तुम मेडिसिन स्टार्ट ही हार्ट साउंड और मर्मर से करते हो, सब बसड़ उधर ही मच जाती है, मेडिसिन पढ़ने का मन नहीं होता. तो दैट आई नो व्हाट हैपेंड. तो उसको पढ़ो ही मत ना. ठीक है ना. छोड़ो ना, एक क्वेश्चन ही होगा ना सॉल्व, बस. Next, if it is a case of uremic pericarditis, then as it is a case of renal failure, therefore the treatment of choice over there will be hemodialysis. And if it is a case of tubercular pericarditis, then the treatment of choice will be ATT plus steroids. ठीक है. 190 तो कर लो यार, 20-20 क्वेश्चन भी ब्रेक में नहीं करेंगे क्या अपन. 189 और लास्ट ब्रेक कब दिया था मैंने? 4:35 ना. हाँ तो अभी होगा, रुको जरा. Question number 189. Lalit, a 19-year-old male, presented to the cardiac OPD with complaints of dyspnea, chest pain following exercise. ठीक है. His elder following exercise ही chest pain है. That means when the demand increases, then only the patient is having pain. His elder brother had same symptoms and he died 2 years ago. by sudden collapse while participating in a marathon event. ठीक है, क्लासिकल है ये, सरकारी क्वेश्चन है. On examination, jerky pulse and double apical impulse on palpation. Narrow split as to crescendo decrescendo murmur. Classical. कम से कम ये तो याद रख सकते हो, crescendo decrescendo murmur is seen in HOCM. ठीक है, is heard on auscultation. Genetic analysis shows. अब और क्या चाहिए? Beta myosin gene mutation. This was the question in FMGE examination. They have asked, in a case of hypertrophic obstructive cardiomyopathy, which is the gene mutation? Answer was beta myosin heavy chain gene mutation. Please remember that. ठीक है? Which of the following is the best treatment? So diagnosis, we know it is a case of HOCM, hypertrophic obstructive cardiomyopathy. It usually affects, as it is due to gene mutation, it will commonly affect young adults or adolescent patient. When the patient is running on the field, marathon, football, the patient suddenly collapses. He's having a lot of chest pain and the patient suddenly dies. Okay, so sudden cardiac death ho jati hai is patient mein. That is a likely case of hypertrophic obstructive cardiomyopathy. They can also give history of cardiac death in the sibling as well. Okay, so that is very commonly seen over here. Now, definitely, crescendo decrescendo murmur is a characteristic feature of that. Okay. Now, what is the best treatment they are asking? As you can see, there is hypertrophy of the septum over here. As there is hypertrophy of septum, therefore the left ventricular outflow tract is obstructed, and therefore the blood cannot go out into the aorta. Okay, there is decreased blood supply to the aorta. Therefore, the patient has decreased blood supply to the heart, and that leads to severe chest pain in the patient due to ischemia. Okay. Now, important is, what is the best treatment? Normally, if they have asked you, what is the drug of choice for prevention? Drug of choice for prophylaxis, okay? मतलब the patient is a known case of HOCM. अब इसको आगे जाके दिक्कत ना हो, इसके लिए drug of choice क्या है? Drug of choice for prophylaxis. Answer is propranolol, beta blocker. But if they ask you what is the treatment of choice? Treatment of choice is alcohol based septal ablation. जो hypertrophic septum है, उसको जला दो, okay? But ये क्वेश्चन प्रीवियस ईयर था एंड नीट पीजी में दूसरा क्वेश्चन था, ये नीट पीजी वाला क्वेश्चन है. एंड एज यू नो मी, तो फिर एक तो गूगली बनती थी. सो डेफिनेटली हियर द ट्रीटमेंट ऑफ चॉइस इज अल्कोहल बेस्ड सेप्टल अब्लेशन, बट हियर दे आर गिविंग हिस्ट्री ऑफ sudden cardiac death in the sibling, and if there is a history of sudden cardiac death in the sibling, or if there is history of any other cardiac disease in the patient, in that patient we cannot go for alcohol based septal ablation as the best choice. In that patient the best treatment will be implantable cardioverter defibrillator, ICD. अगर history of sudden cardiac death है family में, then alcohol based septal ablation is not the treatment of choice. Then it is definitely implantable cardioverter defibrillator. No issues with this. ICD is generally used in anybody. ICD is generally used in implantable cardioverter defibrillator. A, B, C. बोला तो था. A for ARVD, that is arrhythmogenic right ventricular dysplasia. नाम याद रखना है, कोई नहीं पूछ रहा डीप में. Arrhythmogenic right ventricular dysplasia. And second is left ventricular aneurysm. B for a sodium channel defect. ये तो नाम पता होना चाहिए. Brugada syndrome, sodium channel defect कम से कम. C for cardiomyopathy. Which cardiomyopathy? Hypertrophic cardiomyopathy. When there is history of sudden cardiac death in the family. कोई दिक्कत नहीं है. So these are the ABC are the indication of implantable cardioverter defibrillator, ICD. ठीक है? Cardiac transplant is the treatment of choice for which type of cardiomyopathy? Dilated cardiomyopathy, DCMP, and RCMP, that is restrictive cardiomyopathy. दोनों में cardiac transplant will be the treatment of choice. बोलो हाँ. क्या? Sibling की history के बाद आंसर इसलिए चेंज होता है because in this patient even if you try to do alcohol based septal ablation, here the HOCM is due to beta myosin gene mutation, and as it is due to beta myosin gene mutation, एक बार alcohol septal ablation कर भी दोगे, वापस से hypertrophy हो जाएगी क्योंकि वो जीन खराब है उसकी जीन ही खराब है. तुम कितना भी ट्राई कर लो, वो वापस हाइपरट्रॉफी होती रहेगी. तो ऐसे पेशेंट में अपन बार बार अल्कोहल बेस्ड सेप्टल अब्लेशन नहीं कर सकते. इसीलिए इट्स बेटर टू प्लेस अ डिफिब्रिलेटर. जब भी पेशेंट अरिथमिया में जाने की रिस्क रहेगी, इट विल इमीडिएटली डिटेक्ट द अरिथमिया, इट विल इमीडिएटली गिव अ शॉक टू द पेशेंट एंड दैट पेशेंट विल बी करेक्टेड. ठीक है. डिफिब्रिलेटर क्या होता है भाई? इट इज एक्चुअली अ इम्प्लांटेड मशीन. वो क्या करती है? जैसे ही अरिथमिया डिटेक्ट होता है, वो इमीडिएटली पेशेंट को शॉक देती है और इमीडिएटली रिदम नॉर्मल हो जाती है. ठीक है. So that is what is a implantable cardiac defibrillator. Next generation में there is a very high chance, almost it is a dominant pattern of inheritance, autosomal dominant. मतलब usually around 50% patients will have HOCM. अगर माँ बाप में है 4 बच्चे हो तो उसमें से 2 में तो होगा ही होगा. हाँ तो हाँ तो ICD इसीलिए नेक्स्ट जनरेशन में भी चांस तो होगा. ठीक है. नो इश्यूज विद दिस एनीबॉडी. क्वेश्चन नंबर 190. An adult complains of palpitation and breathlessness on examination, irregular pulse. ये कैरेक्टरिस्टिक है. As soon as they mention irregular pulse or they mention irregular rhythm, diagnosis is directly atrial fibrillation. Heart rate of the patient is 120 beats per minute. Blood pressure is 110/70. Which of the following is found in the patient? We know it is a case of atrial fibrillation. That means normally कितनी waves होती है ECG पे? 3. Due to atrial contraction wave. P A wave कब आ जाती है भाई? It is the P wave definitely. Then definitely due to ventricular contraction, it is the QRS complex, and due to ventricular relaxation, it is the T wave. So, as in a case of atrial fibrillation, atria are only fibrillating. Are they contracting completely? No. As they are only fibrillating, will the P wave on ECG will be produced? No. So ECG पे क्या नहीं दिखेगा तुम्हें? P wave will be absent. P wave is absent, but what is seen? A fibrillating wave is seen in between the QRS complex. The QRS complexes will be normal or abnormal? Normal. याद रखना कोई भी एट्रियल पैथोलॉजी में द क्यूआरएस कॉम्प्लेक्सेस आर ऑलवेज नॉर्मल. तो सबसे पहले अगर कोई चीज देखोगे तो क्यूआरएस कॉम्प्लेक्स देखते जाओ ईसीजी पे. अगर क्यूआरएस कॉम्प्लेक्स नॉर्मल है मतलब इट इज नॉट अ वेंट्रिकुलर पैथोलॉजी, इट इज अ एट्रियल पैथोलॉजी. देन विल सी वेदर इट इज एट्रियल फिब्रिलेशन, एट्रियल फ्लटर और इट इज अ पीएसवीटी. ठीक है. तो दैट इज इंपॉर्टेंट. अगर तुम्हें बस फिब्रिलेटिंग वेव दिख रही है दैट मींस इट इज अ केस ऑफ एट्रियल फिब्रिलेशन. अगर तुम्हें एक सॉट टूथ अपीयरेंस दिख रहा है दैट इज अ केस ऑफ एट्रियल फ्लटर. सॉट टूथ अपीयरेंस ऐसा होता है कुछ. ठीक है. That is the atrial flutter. And if you are able to see overriding of QRS complex and T wave, that is the case of PSVT. ठीक है. यहाँ देख लो in atrial flutter and atrial fibrillation, second difference. In atrial flutter, the RR interval or the rhythm is regular or irregular? Regular. In atrial flutter, it is regular. But in atrial fibrillation, it is irregular. In atrial fibrillation, it is irregular. You can see the distance between RR interval is unequal over here. That means it is an irregularly irregular rhythm. Irregularly irregular rhythm is not a feature of flutter. It is a feature of fibrillation only. ठीक है. So irregularly irregular rhythm or irregularly irregular pulse, characteristic of fibrillation in the patient. No issues with this anybody? Now if I talk about JVP, JVP में कितनी waves दिखती है फट से? A wave, C wave, X descent, V wave and Y descent. So A, C, X, V, Y. A wave is due to atrial contraction. C wave is due to atrial contraction. Please remember. ठीक है. C wave is due to vena caval. Sorry, it is due to bulging of the tricuspid valve usually. That is during isovolumetric contraction. So C for contraction याद रखना है. Then X descent is due to ejection period. ये mnemonics बता रहा है, ऐसे याद रखते हैं. X descent is due to ejection period when blood goes out of the heart. Then V wave is due to ventricular filling when the vena cava is filling. Sorry, when the ventricular vena cava is filling the atria. Vena caval filling. And lastly, Y descent is due to atrial. याद कैसे रखना है देखो. A wave is due to atrial contraction. So A for A. Then C wave is due to when all the definitely or the aortic valve is closed and the ventricles are getting filled, and after that the ventricles close. Now all the valves are closed and the ventricles are contracting. This is called as isovolumetric contraction. Due to that the pressure rises, and due to that we see the C wave usually. So C for contraction. Which contraction? Isovolumetric contraction. Then there is the X descent. X descent is when blood goes out of the heart. That is called as ejection period. ऐसे याद रखोगे, easy है. Then V, when the vena cava will fill the atria. So vena cava causing atrial filling Pressure in the atria rises, that causes this V wave. And finally, definitely what happens now? Atrial emptying. Blood from the atria goes into the ventricle. And as the blood goes into the ventricles, definitely what will happen? The pressure in the atria decreases, and therefore we can see a Y descent. Please remember, no issues with this, anybody? Please remember, what is JVP? JVP, jugular venous pressure. That means the pressure inside the internal jugular vein. Internal jugular vein drains into the superior vena cava, and superior vena cava finally drains into the right atria. So if there is any change in the pressure inside the right atria, that will be reflected to the superior vena cava, that will be reflected to the internal jugular vein. Therefore, any pressure change in the right atrium will cause increase or decrease in the pressure of internal jugular vein. अब समझ गए? तो that's the basic idea you need to remember. अगर एट्रिया कॉन्ट्रैक्ट होते तभी ए वेव दिखती है. इसमें एट्रिया क्या हो रहा है? बस फिब्रिलेट. तो ए वेव बनेगी? नहीं बनेगी. So it is an absent. ठीक है? So please remember, absent A wave is seen. 2 बार NEET-PG, 1 बार जी. Question has been repeated. And बहुत easy है. irregular देखते हैं. Atrial fibrillation. Atrial fibrillation contract ही नहीं हो रहा तो ना P wave बनेगी ECG पे, ना A wave दिखेगी JVP पे. That's important बता रहा हूँ. Absent A wave, atrial fibrillation. Steep X descent, cardiac tamponade. And steep X plus steep Y descent, constrictive pericarditis. These three have been asked in your examination already. These three. Question number 191. A patient of diabetes mellitus who presents with output. Diabetes mellitus के patient में urine output ज़्यादा होता है. Urine output है, that means which structure or which organ is in kidney. We know the most common cause of chronic kidney disease in India is. This patient has developed what? Diabetic nephropathy, definitely. And there is headache in the patient. Okay, blood pressure is 150 by 100 millimeters of mercury. Q, we know in cases of diabetic nephropathy, the blood pressure of the patient will rise because the fluid is not able to get excrete out. All that fluid remains in the body causing hypertension. So a lot of diabetic nephropathy patients will have simultaneous hypertension also. Okay? GFR is estimated as 50 ml per minute. CKD का बोलते हो anybody? CKD की definition. GFR less than, वो stage 1 हो गई. Normal diagnosis. GFR less than 60 ml per minute per 1.73 meter square plus proteinuria for a span of 3 months is CKD, right? Chronic kidney disease. Okay, that's important. No issues with this. CKD can start from stage 1 when the GFR goes less than 90 ml per minute. But the definition says this one. Okay, that's the basic important. Now, here definitely the patient is in stage 3 already. And the spot urinary sample reveals albumin urea. Because there is proteinuria in CKD. I've told you, kidneys are damaged, so protein bhi waste hota rehta hai. His serum creatinine values are deranged. Definitely in cases of chronic kidney disease or any case of renal failure, what is the marker? Serum creatinine. So serum creatinine will be very, very high. Which among the following is correct as a treatment option in this patient? Okay, important. First of all, if I talk about option B, he is already on metformin for diabetes mellitus. If I increase the dose of metformin, what is going to happen? The patient will suffer from lactic acidosis. Okay, because please remember, metformin is excreted out by kidney. So can we give it in renal failure? No, otherwise there will be toxicity of metformin. Next, start lab tablet losartan, angiotensin receptor blockers. Please remember why they would not be given. Losartan, they are known to cause hyperkalemia in the patient. Already a case of chronic kidney disease will have severe hyperkalemia. Patient will land up into arrhythmias. Okay, so that should not be given. That's the reason. Okay. Next is allogenic kidney transplantation. Transplantation is not the best answer over here. Answer should be shift the patient to insulin because insulin is a safer drug in a case of renal failure also. That's the basic reason. Okay? Question number 192. A patient was brought to an emergency by his relatives. Patient is unconscious and he is unresponsive. On examination, definitely his pulse and breathing efforts are absent. You apply ECG electrodes and following pattern is observed. You start oxygen and initiate CPR. What is the next best step? Now, important is CPR. 2 से 3 क्वेश्चन मिनिमम सीपीआर से आते हैं अगेन, ठीक है। दिस इज अ वेरी हाई यील्ड टॉपिक इन एवरी एग्जामिनेशन। इंपॉर्टेंट, फर्स्ट ऑफ ऑल सीपीआर कब स्टार्ट करते हो भाइयों, ये बताओ। सबसे इंपॉर्टेंट, अगर पेशेंट तुम्हें कोलैप्स मिलता है कहीं, इफ यू फाइंड अ पेशेंट विद कोलैप्स, व्हाट यू विल डू फर्स्ट? देन चेक द सीन सेफ्टी। once you have checked the scene safety, then what you will do? Call for help. Once you have called for help, then what you will do? You will activate the emergency response. Then definitely you will response. Okay, so check the response. Baba jinda ho? Definitely check for response of the patient. If the patient is unresponsive and unconscious, then check for pulse. Okay? Important is, if pulse and breathing both are absent, what you need to do? Pulse absent है, उठ के एक लगाएगा भाई, सीपीआर शुरू करो। आवाज क्यों नहीं आ रही? शाबाश। Shift the patient into lateral position. Reason is there will be high chances of aspiration if the patient is unconscious. तो ये क्वेश्चन था इस बार नीट पीजी का, ठीक है। तो प्लीज रिमेंबर, if pulse and breathing both are present, definitely shift the patient into lateral position to prevent aspiration. क्यों? क्योंकि ये बेवड़ा होगा, दारू पी के पड़ा होगा, ठीक है। So that's the reason usually. No issues with this. Next important is, if breathing is absent, pulse is present, then definitely तुम दोगे या नहीं दोगे, आई एम नॉट श्योर। इट इज माउथ टू माउथ ब्रीदिंग शुड बी गिवन। इफ ऑक्सीजन कैन बी गिवन और वी कैन स्टार्ट IPPV। जानबूझ के बता रहा हूं, जब जरूरत हो तभी। नेक्स्ट इंपॉर्टेंट, इफ पल्स एंड ब्रीदिंग बोथ आर एब्सेंट, then definitely in this condition we will start the BLS. What is BLS? Basic life support, or ACLS, that is advanced cardiac life support. What is the sequence? ABC या CAB? BLS या ACLS में इट इज CAB, सर्कुलेशन एयरवे ब्रीदिंग। बट हमने सर्जरी में जो पढ़ा ATLS प्रोटोकॉल, उसमें इट वाज ABC, एयरवे ब्रीदिंग एंड सर्कुलेशन। दोनों में डिफरेंस है, याद रखना है बात। तो फर्स्ट ऑफ ऑल वी विल नीड टू स्टार्ट चेस्ट कंप्रेशन। So we will start CPR in the patient. Along with that, if you have oxygen, give oxygen, and as soon as defibrillator is available, immediately attach the defibrillator. हाँ, तो वो बोलते हैं कि 2 मिनट में आ गया, 2 मिनट में एक साइकिल भी कंप्लीट नहीं हुई, अटैच द डिफिब्रिलेटर। क्यों? क्योंकि तुम्हें हार्ट रिदम देखनी है। यू नीड टू चेक हिज हार्ट रिदम। तुम सीपीआर दे तो रहे हो, बट यू वांट टू चेक हिज हार्ट रिदम, वेदर इज हैविंग अ टैकियारिथमिया और इज हैविंग अ ब्रैडियोरिथमिया, दैट यू हैव टू चेक। So please remember, the first important thing is, even if you're doing a CPR, even if one cycle is only completed, but if defibrillator is available, attach the paddles. Immediately attach the paddles, and then check for the rhythm. If the rhythm is shockable, what are the shockable rhythms, guys? Ventricular fibrillation or the ventricular tachycardia. Only the unstable ventricular tachycardia मैं बोल रहा हूँ। Stable ventricular tachycardia में, stable ventricular tachycardia, you need to see whether it is stable, मतलब patient गिरेगा ही नहीं सबसे पहले। His blood pressure will be normal. Stable का मतलब यही होता है, okay? तो stable ventricular tachycardia hemodynamically stable patient है। You need to see this monomorphic or polymorphic. Monomorphic ventricular tachycardia, the drug of choice will be IV amiodarone, that is chemical cardioversion. But in polymorphic ventricular tachycardia, it will be IV magnesium sulfate. So Q, polymorphic ventricular tachycardia is nothing but Torsades D pointed. Okay? But if there is a pulseless or a unstable ventricular tachycardia and ventricular fibrillation, then we have to immediately give a DC shock. Kitna? 200 joules by physics. Okay, and we need to immediately continue CPR. Yaad question was in the recent FMGE examination, you have given shock. What is the next best step? जैसे ही शॉक देते हो इमीडिएटली सीपीआर शुरू करो। नेक्स्ट शॉक नहीं रहे, रुक जाओ थोड़ा। तो प्लीज रिमेंबर, एक शॉक देते हो, इमीडिएट स्टार्ट सीपीआर। क्यों? शॉक का काम, शॉक मेक्स द हार्ट स्टैंड स्टिल। उसको वापस अगर चलवाना है तो यू नीड टू स्टार्ट सीपीआर, अदरवाइज पेशेंट का हार्ट ऐसा कैसा, शॉक दिया ठीक हो जाए, चलो वो निकल लिया तब तक, ठीक है। तो इमीडिएट सीपीआर शुड बी स्टार्टेड। प्लीज रिमेंबर, along we also need to get a intravenous or intraosseous access and start IV fluids, as well as we need to give another drug is, okay? Again, if the rhythm is shockable or not, अगर नहीं है तो सेकंड टाइम शॉक दे दो, ठीक है। सेकंड टाइम शॉक के बाद इमीडिएटली सीपीआर शुरू करो। सेकंड टाइम के शॉक के बाद भी इफ द पेशेंट पल्स इज नॉट कमिंग बैक, देन वी कैन गिव एपिनेफ्रिन। कितना? 1:10,000 dilution intravenous route cardiac arrest, 1:1000 dilution intramuscular anaphylactic shock में दिया जाता है वो, ठीक है। Then again check the rhythm, third time shock दो, okay, third time shock देने के बाद you can start amiodarone and lidocaine, but important 3 shock के बाद अगर नहीं revive होता तो जाने दो बेचारे को, टाइम खत्म हो गया सर, ठीक है। So that is what is done usually. Next, if there is a non-shockable rhythm, what are non-shockable rhythms? Asystole, that is you are able to see a straight line, or second is you are able to see pulseless electrical activity, PEA, okay, pulseless electrical activity, pulse तो नहीं आ रही but छोटी छोटी electrical activity दिख रही है बस। So in that condition you will start CPR in the patient immediately, but here before giving shock, what is your priority? To give epinephrine to the patient. So pulse for non-shockable rhythm, the first line management is epinephrine. For shockable rhythm, the first line management is DC shock. Okay, so that's the basic difference. Okay, here we don't give DC shock unless and until the patient goes into shockable rhythm. तो हम rhythm check करते रहते हैं, जैसे shockable rhythm हो गई, then definitely we can start the shock. But unshockable rhythm में, non-shockable rhythm में never give DC shock to the patient. तो जिन्होंने electrical cardioversion मार्क किया है, तो भाई मत करना ऐसा. This is the case of pulseless electrical activity. ECG क्या दिखा रहा है? Activity दिख रही है ना? Proper activity है क्या वो? नहीं है. And pulse is absent. So it is a case of pulseless electrical activity. Shockable or non-shockable rhythm? Non-shockable. Can you give electrical cardioversion in non-shockable rhythm? Absolutely contraindicated. Chemical cardioversion, amiodarone, not the first line management. Next best step will be injection of epinephrine, intravenous IV, 1:10,000 dilution. Question number 193. A young patient was brought to with complaints of fatigue and recurrent syncopal episode. 2 बार रिपीट हुआ ये ECG तुम्हारे एग्जाम में इजी है बहुत, ठीक है। फटीग एंड रिकरेंट सिंकोपल एपिसोड मतलब बार बार चक्कर आके गिर जाता है पेशेंट। सिंकोपल एपिसोड इज बार बार पेशेंट फेंट होता है या चक्कर आके गिर जाता है। क्यों? सिंकोप कब होता है? व्हेन देयर इज डिक्रीज ब्लड सप्लाई टू द ब्रेन, तब सिंकोप होता है, ठीक है, याद रखना है बात। इंट्राओशियस मतलब हम वेसल में ही जा रहे हैं, इंट्राओशियस में भी बोन में ही डायरेक्टली जा रहे हैं। बोन में कौन सा? बोन में हमें वेसल में घुसना है डायरेक्ट, दैट्स द इंपॉर्टेंट, ठीक है। 24 hour होल्टर ECG मॉनिटरिंग वाज डन एंड द स्नैप इज गिवन। व्हाट इज द बेस्ट ट्रीटमेंट ऑप्शन? 24 hour का ECG मॉनिटरिंग किया गया था। द रीजन वाज, प्लीज रिमेंबर, क्योंकि एक ECG में हमें कुछ नहीं दिखा, तो वी थॉट कि वी विल डू अ 24 hour ECG होल्टर मॉनिटरिंग, और एक स्नैपशॉट में हमें ऐसा दिख गया। क्या दिख गया? Sometimes the RR interval is very short. That is suggestive of tachybrady, tachycardia, and in some cases definitely there is more interval between the RR interval. That is suggestive of bradycardia. So there are some episodes of tachy, some episodes of brady. That is tachybrady syndrome, also known as sixth sinus syndrome. Sixth sinus syndrome में क्या डैमेज होती है उसकी? कौन पेसमेकर ऑफ हार्ट कौन है? एसए नोड। तो एसए नोड ही पागल हो गई यहाँ पे, कभी कभी ज्यादा बीट कर रही है, कभी कभी धीरे धीरे बीट कर रही है, ठीक है। सो दैट्स द इंपॉर्टेंट थिंग। सिक्स साइनस सिंड्रोम इज नथिंग बट देयर इज सम प्रॉब्लम विद द एसए नोड इटसेल्फ दैट कॉजेस सिक्स साइनस सिंड्रोम, आल्सो नोन एज टैकीब्रैडी सिंड्रोम, ठीक है। सो व्हाट इज टू बी डन? अगर उसका पेसमेकर खराब है तो बाहर से क्या लगा दो? पेसमेकर लगा दो। तो ट्रीटमेंट ऑफ चॉइस इज पेसमेकर इन द पेशेंट। रेडियो फ्रीक्वेंसी अब्लेशन इज डन इन केसेस ऑफ Wolff-Parkinson-White syndrome. Radio frequency ablation is done in cases of WPW, Wolff-Parkinson-White syndrome, even in cases of Lown-Ganong-Levine syndrome. Question number 194. A 30-year-old female presents with weakness and dry skin. On auscultation, soft heart sounds were noted. Heart rate is 50 beats per minute. मतलब bradycardia. Lab value shows high TSH. High TSH है तो उससे तुम्हारा डायग्नोसिस होता है। वी डोंट नीड T3 एंड T4 फॉर मेकिंग अ डायग्नोसिस, वी ओनली नीड TSH। TSH अगर हाई है, दैट इज अ केस ऑफ हाइपोथायरॉयडिज्म या हाइपरथायरॉयडिज्म। इट इज अ केस ऑफ हाइपोथायरॉयडिज्म। बेसिक है, हाइपो में क्या होता है? फिजियो T3 T4 लो होता है, और T3 T4 लो है तो नेगेटिव फीडबैक जाएगा क्या? नहीं जाता, और नहीं जाता इसलिए पिट्यूटरी को क्या लगता है कि T3 T4 की बहुत ज्यादा कमी है, so therefore it keeps on secreting TSH. So please remember, in cases of hypothyroidism, TSH will be very, very high, and in cases of hyperthyroidism, as there is more T3 and T4, immediately a negative feedback goes, therefore the TSH values are low. So that's important. No issues with this, anybody? High TSH is suggestive of hypothyroidism. Most common cause of hypothyroidism worldwide. Worldwide. Goiter, that is iodine deficiency. India, Hashimoto's thyroiditis. And our diagnosis is confirmed further because investigation of choice for Hashimoto's thyroiditis is anti-TPO antibody, anti-thyroid peroxidase antibody. Thyroid peroxidase is the rate limiting enzyme of thyroid hormone synthesis. उसी के against antibody है, तो T3 T4 बनेंगे क्या? नहीं बनेंगे. That's why the patient is in hypothyroidism. Now below given biopsy finding is seen. Below given biopsy finding में क्या दिख रहा है? What are these pink color cells, anybody? बराबर बोलो. Arthal cells. These are the classical cells. And along with that, definitely, what is seen over here? Excessive blue color cells. छोटे छोटे क्या है वो? Lymphocytes. So excessive lymphocytes are generally seen. Lymphocytic infiltration along with Hurthal cells are biopsy findings seen in a case of Hashimoto's thyroiditis. And Hashimoto's thyroiditis is nothing else but a chronic lymphocytic thyroiditis. ठीक है? D-Quervain's thyroiditis. D-Quervain's thyroiditis में क्या दिखता है usually? Again, you see lymphocytic infiltration a lot. Okay, there will be formation of numerous granulomas. That is a characteristic feature of D-Quervain's or a granulomatous thyroiditis. It is acute, subacute या chronic? Subacute thyroiditis. ठीक है? Hashimoto's is chronic, but D-Quervain's is subacute thyroiditis. मतलब T3 T4 की लेवल्स कम होंगी, but ज्यादा कम होगी या थोड़ी कम होगी? थोड़ी सी कम होगी. ठीक है? So that is what is subacute. No issues with this, anybody? And जब थायराइड ग्लैंड पूरी हार्ड हो जाती है, यू आर नॉट वेरी गुड, इट इज नोन एज रीडल्स थायरोइडाइटिस. रीडल्स थायरोइडाइटिस में इट बिकम्स वुडी हार्ड. ओके, ड्राई टाइप आएगा, मतलब ड्राई बायोप्सी आएगी तुम्हें. ठीक है, सो दैट्स इंपॉर्टेंट. Question number 195. After total thyroidectomy under general anesthesia, anesthetist tried to extubate, but the patient, he was unable to extubate the patient. When he removes the tube, the patient begins to have recurrent cyanotic spells. What is cyanosis? Blue color discoloration, and that is due to decreased oxygen, decreased partial pressure of oxygen in the blood. What is the most probable reason? चलो ये बताओ दो मुझे. All intrinsic laryngeal muscles lie inside the larynx or outside the larynx? Inside the larynx, except cricothyroid, which lies outside the larynx. Therefore, all intrinsic laryngeal muscles are innervated by recurrent laryngeal nerve, except cricothyroid, which is innervated by superior laryngeal nerve. की कौन सी branch? External branch. Therefore called as external laryngeal nerve. Now, if there is bilateral RLN palsy in the patient, bilateral RLN palsy in the patient, क्या हो जाएगा? All the muscles will stop working. So सब muscles stop working except cricothyroid. Cricothyroid is the only muscle which is working. Cricothyroid is the main tensor muscle. It gives quality of voice. But उसका दूसरा भी काम है. It is also a adductor muscle. All other muscles are gone. Only one muscle is working, which is causing adduction. तो vocal cords किस position में आ जाएंगे? Closed position. So here, therefore, the vocal cords will come in adduction or in the closed position, जैसे दिख रहा है laryngoscopy पे. And therefore, the patient will have what? Respiratory distress. Along with that, obstruction causes stridor. But the patient will have voice. Okay, perfect तो नहीं होगी, but हाँ, the patient can produce voice definitely. There will not be aphonia in the patient. Okay, so that is seen in case of bilateral RLN injury, also known as bilateral adductor palsy or abductor palsy. किसकी palsy है? Abduction की palsy है ना? So it is a bilateral abductor palsy. ठीक है? Whereas अगर मैं बोलूं, if there is bilateral adductor palsy, कब होगी bilateral adductor palsy? When SLN plus RLN both are injured, that means incomplete vagal palsy itself. दोनों की दोनों nerves अगर paralyze हो जाती है, दोनों की दोनों nerves injured हो जाती है, none of the laryngeal muscle are working. Therefore, the vocal cords will come into which position? They will come into lie in the intermediate position. या dead body में जैसी position होती है, that is cadaveric position. Now the vocal cords are open always, and as the vocal cords are open, the patient will not be able to produce voice. That is aphonia. Along with that, there will be high risk of aspiration causing pneumonia and abscess. ठीक है? That is important. तो अब बताओ मुझे, as the patient is, see, extubation में problem क्यों आ रही थी? Because both the recurrent laryngeal nerves were injured during surgery. Therefore, now the cricothyroid is bringing the vocal cords in closed position, and you have inserted a tube over here. ठीक है? You have inserted a tube over here. अब निकाल पाओगे क्या tube? Vocal cords closed है ना, तो इसीलिए उसको दिक्कत आ रही थी. But finally कैसे भी करके उसने निकाल दिया, भले इंजरी होगी. But now जैसे उसने ट्यूब निकाली, अब बहुत छोटा सा गैप है, so will the patient be able to breathe? No, he is having respiratory distress, and due to which oxygen की कमी है, that causes cyanotic spells in the patient. So here the cause is due to bilateral RLN injury. Unilateral RLN damage बच्चों only causes hoarseness of voice. It only leads to hoarseness of voice. And SLN damage causes what? Poor quality of voice. Okay. Usually that too not unilateral, bilateral SLN. Bilateral SLN injury causes poor quality of voice because the vocal cords are in which position? चलो दोनों क्वेश्चन आ चुके हैं, इससे मैं बता रहा हूँ. SLN injury, SLN की दो branches है. One is internal laryngeal nerve and second is external laryngeal nerve. External laryngeal nerve supplies which muscle? Cricothyroid. Cricothyroid is the main tensor muscle. It stretches the vocal cords and gives better quality of voice. Therefore, if external laryngeal nerve is injured, cricothyroid muscle will be paralyzed, and therefore the vocal cords will be in bowed down position. The quality of voice will be better or poor? Poor quality of voice. Next, the second branch was internal laryngeal nerve. It supplies, it gives motor innervation or sensory innervation. Sensory innervation. It supplies the mucosa to which part of the larynx? Supraglottis, glottis, or the subglottis? Supraglottis. Shabash. Supraglottis में sensory innervation is given by the internal laryngeal nerve. Recent FMG question 2023 का बता रहा हूँ. ठीक है? Now definitely, if internal laryngeal nerve is damaged, there will be loss of sensations from the supraglottis. Will there be cough reflex? No. So patient कुछ भी आएगा directly कहाँ जा सकता है? Lungs में. There will be high risk of aspiration. That is recurrent aspiration. So if there is SLN nerve injury, there will be poor quality of voice due to ELN injury, and there will be recurrent aspirations due to ILN injury. Okay? So that is important. That has been asked multiple times in examination. Don't make a mistake over there. Question number 196. 200 कर लो, ले लो break. Question number 196. A 40-year-old alcoholic male patient presented to emergency with acute abdominal pain and there is distension. A fluid-filled lesion is present in the epigastrium. Which of the following parameter is raised? What is this? 40-year-old alcoholic male. Alcoholic males having abdominal pain. What is the likely cause? Pancreatitis, right? And usually after a case of acute or chronic pancreatitis, the patient develops distension of abdomen because a complication which is there known as, very good, shabash, a pancreatic pseudocyst. That is the complication after acute as well as chronic pancreatitis, right? So this pseudocyst which is formed, it will compress the stomach. That causes epigastric fullness, there will be nausea, vomiting, postprandial fullness, okay, all of these features, abdominal distension, तो इसकी वजह से हो रहा है वो. Now definitely, if it is a case of pancreatitis, बस इतना ही देखना था. Even इतना भी देता तो भी तुम्हारा आंसर वही होना चाहिए. Alcoholic male, acute abdominal pain, diagnosis is likely pancreatitis. What is the best investigation of the parameter? It is serum lipase followed by serum amylase. So best investigation for diagnosis of acute pancreatitis, answer is serum lipase levels followed by serum amylase. Why amylase is not the most specific or the best one? It is also present in saliva. Yes, very good. It is not specific. ठीक है? अगर वो liver abscess जैसा कुछ features देते, hepatomegaly देते, right upper quadrant pain देते, तो definitely यहाँ पे तो क्या मार्क करा जाता? Bilirubin मार्क करा जाता. But better would have been ALT, right? So that's important. Question number 197. A 30-year-old female presented to the hospital with abdominal pain, weight loss, and sterile pyuria. ठीक है? Pyuria मतलब pus cells are present inside the urine. Radiograph is given below. What is the most likely diagnosis? So now, what is your provisional diagnosis? It is a case of renal TB. Usually, a case of abdominal pain along with weight loss, na? And characteristic feature of renal TB is sterile pyuria. Okay, characteristic feature of renal TB on urine microscopy is sterile pyuria. जैसे sterile pyuria आ जाता है, please think in terms of renal tuberculosis. Radiograph is given below. Now we know just finding which is seen on IVP, ulcer leading to finally Moth-Eaton colitis. Finally, it progresses to kidney. Then there will be calcification of the kidney known as putty kidney. And finally, there will be hardening of kidney known as cement kidney. And finally, there will be complete damage of kidney called as autonephrectomy. Okay? So definitely it is a case of putty kidney. Can anybody tell me it is a plain X-ray or a IVP? मुझे टेंशन आ रहा है कि मैंने सर्जरी पढ़ाई है ना नहीं पढ़ाई, यही नहीं समझ आ रहा मुझे. तो प्लीज रिमेंबर, डाई दिख रहा है क्या तुम्हें यूरिनरी ब्लैडर में? यूरेटर दिख रहा है क्या तुम्हें? नहीं दिख रहा है ना? तो इट इज अ केस ऑफ, इट इज अ प्लेन एक्सरे केयूबी. ओके, इट इज अ एक्सरे केयूबी. मैंने बोला था अगर डाई नहीं दिख रहा है, इट इज अ एक्सरे केयूबी. और एक्सरे पे अगर कुछ सफेद दिखता है, दैट इज सजेस्टिव ऑफ कैल्सिफिकेशन और बोन. तो डेफिनेटली हियर यू आर एबल टू सी सम कैल्सिफिकेशन. एक्सरे केयूबी पे दो चीजें कैल्सिफाइड दिख सकती है प्लेन एक्सरे केयूबी पे. If you are able to see the shape of kidney, then it is a case of putty kidney. But on a plain X-ray KUB, if you are able to see the shape of the renal pelvis and the calyx, then it is a case of Staghorn calculi. This is also X-ray KUB itself, right? No Diana. Therefore, it is a case of Staghorn calculi. So plain X-ray KUB pe two things can appear white due to calcification. If it is the shape of kidney, answer is putty kidney. If it is the shape of renal pelvis and calycis, then the diagnosis is Staghorn calculi. कोई दिक्कत नहीं है इसमें. So don't make a mistake. This is a very common question in your exam. NEET-PG and FMGE. This is a case of, this is IVP or this one plain X-ray. This is a case of IVP. Okay, you are able to see the dye in both of them. So definitely क्या दिख रहा है यहाँ पे? There is some blockage, and due to that, definitely the renal pelvis and the calycis have been dilated. This is called as hydronephrosis. So usually IVP पे अगर तुम्हें dilated renal pelvis and calycis दिख रहा है, that is the case of hydronephrosis. Hydronephrosis के बहुत सारे causes हो सकते हैं. We have discussed that. It can be PUJ obstruction. It can be multiple other causes as well. ठीक है? Question number 198. A 25-year-old patient presented to the emergency with history of road traffic accident. On examination, the patient had subcutaneous emphysema, shortness of breath, absent air entry of right hemithorax, and hypotension as well. Okay, decreased blood pressure. Which of the following will be the next step in management? Provisional diagnosis batao. Shabash. It is a case of tension, pneumothorax. Do you need an X-ray? No. For a diagnosis. Clinical diagnosis का ABC फट से. शाबाश. एक टर्म्स में बराबर है, बट टेंशन न्यूमोथोरैक्स का पूछ रहा हूं ना मैं भाई. क्या दिया था मैंने? एब्सेंट एयर एंट्री एंड एब्सेंट ब्रेथ साउंड्स ऑन affected side or opposite side? Definitely on the affected side, right? Next, B stands for breathlessness, that is shortness of breath बोलेंगे, respiratory distress बोलेंगे, whatever they call it. ठीक है? And C stands for congested neck veins. Okay, congested neck veins. This will help you make the clinical diagnosis of tension pneumothorax. You don't even need a chest X-ray. क्यों? क्योंकि without a chest X-ray, you have to insert the needle directly. ठीक है? So that's the reason. Based on these three findings, you are making a diagnosis of tension pneumothorax. And what is the immediate step? Needle decompression, also called as thoracocentesis. You will insert a wide bore needle in which space? Fifth intercostal space. In which line? Just anterior to mid axillary line in an adult. Child may it will be inserted in second intercostal space. On which line? Mid clavicular line. Okay? This is the emergency management. What is done for definitive management, guys? ICT insertion with the underwater seal. In which space? Fifth intercostal space. In which triangle? Triangle of safety. कोई दिक्कत नहीं है इसमें. It is important. ठीक है? जल्दी से बताओ. एक्सरे में बहुत बार बता चुका हूं ये वाला. I'm not repeating it. सबसे पहले क्या दिख रहा है? There is a lot of air in which cavity? Pleural cavity on the right side. Therefore, what has happened? The lung, it is not able to expand. Therefore, the lung is collapsed. Next, there is a lot of air. Air appears black or white on X-ray. Black. Therefore, there is increased blackening on the affected side called as hyperlucency. Then the costophrenic angle which is there, it is deep or shallow. It's known as with sign, deep, sulcus sign. Then diaphragm will have a curvature or it will be flattened due to pressure from above. Of diaphragm shifted to same side or the opposite side. Opposite side. So trunk contralateral tracheal shift. These are the X-ray tension pneumothorax. Okay? 199. A 28-year-old pregnant female presented to your clinic with complaints of pruritus, that is itching, and whitish vaginal discharge. Microscopic examination of fluid reveals fungal hyphae, itching and fungal hyphae with whitish discharge. Which among the following shall be used for treatment? Provisional diagnosis is vaginal candidiasis. Okay. Vaginal candidiasis is more common during pregnancy. Why? Because candida needs which kind of medium? Acidic or alkaline? Acidic medium. And here the pH will be less than 4.5. Therefore, there are high chances of candida albicans infection. Alba ka matlab white. Therefore, everything with white. There will be a white, curdy, dahi jaisa, yeah, cottage cheese like vaginal discharge usually. Okay, and fungal hyphae seen, that is diagnostic because the other causes of vaginitis are usually bacterial and protozoal. Okay, so that's basic. So, क्या देना चाहिए? Drug of choice for vaginal candidiasis. Tablet fluconazole 150 milligram stat for the woman, and only if the male partner is symptomatic, then to the male partner. कौन सा ऐसा condition है जहां पे both the partners are treated irrespective the patient has symptom or not? Trichomoniasis. And which is the condition where male partner is never treated? Bacterial vaginosis. जल्दी से बताओ भैया क्या है फर्स्ट वाला? क्या दिखा रहा है? Strawberry vaginal colposcopy, also known as colpitis macularis. What kind of discharge is seen? Green, frothy discharge is seen. This is the case of trichomoniasis caused by Trichomonas vaginalis. Which kind of motility it has? Twitching motility. It will, okay, so please remember, it will be seen on a saline KOH mount usually. Okay, please remember that. No issues with this. It will be seen in alkaline pH more than 4.5 usually. Drug of choice will be metronidazole. Single partner, both partner. Both the partners के लिए 500 mg BD or TDS for 7 to 14 days. This is the case of curdy white discharge. That is the case of candidiasis. I've discussed this. Next, what is this? Whitish discharge, but curdy or thin? Thin watery discharge बोलेंगे वो, ठीक है? तो thin watery whitish discharge. Okay, this is the case of bacterial vaginosis. Diagnosis के लिए कौन सा criteria? Amsel's criteria. What are the 4 features of Amsel's criteria? First, pH should be more than 4.5. That is alkaline pH is required. Second, which kind of discharge? Thin, watery, whitish discharge. That is the second feature. Third, if we take a sample, we will see vaginal epithelial cells loaded with bacteria known as the clue cells. And next, important, there will be whiff test will be positive. That means the discharge, when we add potassium hydroxide to it, it will give a very bad ammoniacal or a fishy smell. That is, fish test will be positive. Okay. Now, important is what is the causative agent of bacterial vaginosis? Gardnerella vaginalis, Mobi-Lincus. But which bacteria decreases? Lactobacillus. So normal bacteria in vagina is known as lactobacillus. वो कम हो जाता है और pathogenic bacteria बढ़ता है. That is what is bacterial vaginosis. Most common type of vaginitis is bacterial vaginosis. Drug of choice is metronidazole. The partner is never treated. Only female is given the drug. ठीक है? Last 200. A lady presents with history of recurrent abortions at 8 weeks, 11 weeks, and 22 weeks. Okay. If there are more than equal to 3 abortions, that is suggestive of recurrent pregnancy loss. Usually, most common cause of abortion, anybody? Iska nahi. Normally, most common cause of abortion, chromosomal abnormality. Most common cause of abortion in first trimester, chromosomal abnormalities. Most common cause of abortion in second trimester, anatomical defect. Most common anatomical defect causing second trimester abortion. Very good. Incompetent os, that is cervical incompetence or a short cervix less than 2.5 centimeter because it cannot hold the pregnancy beyond second trimester. Please remember that. No issues with this. Here the patient pregnancy loss. Okay. History of preeclampsia in the previous pregnancy. What is the most probable cause? Apla syndrome. Why important? Torch group of infection like toxoplasma, others like syphilis, rubella, cytomegalovirus, and herpes virus. Infection only once, and the patient will get a lifelong immunity. Therefore, it will only cause abortion once. It cannot be a cause of recurrent pregnancy that can be pulled out. Gestational diabetes mellitus, does it cause abortion or any defect for that matter? No. Gross congenital anomalies, GCA, are never associated with gestational diabetes mellitus. Why? Gestational mellitus means hyperglycemia after how many weeks of pregnancy? After 24 weeks of pregnancy usually. Okay? Till that, the organogenesis period is already over. So congenital anomalies will be seen in which kind of diabetes mellitus? Overt or pre-existing diabetes mellitus when there is hyperglycemia during the first trimester of pregnancy. Okay? Next, incompetent cervix is the cause definitely for second trimester abortions, but it's not the cause for first trimester abortions. And second important, preeclampsia cannot be explained with it. So definitely APLA syndrome. What is APLA? Anti syndrome. In antiphospholipid antibody syndrome, to make a diagnosis, one clinical and one lab feature should be present. Clinical criteria matlab either the patient should have vascular thrombosis, matlab history of DVT for an example. The patient should have pregnancy features like there should be death of one normal fetus more than equal to 10 weeks. So 10 week या 10 weeks से ज़्यादा का बच्चा without any problem should have been aborted or miscarriage हो चुका हो. First thing. Second, premature birth at less than equal to 34 weeks due to preeclampsia. Third, there should be more than equal to 3 consecutive abortions less than 10 weeks. Placental insufficiency at less than 34 weeks usually. These are the 4 pregnancy wala criteria, at least one of them. Next, lab criteria की अगर मैं बात करूं, which antibody should be there? Anti-cardiolipin antibody, IgG or IgM. This is anti-beta 2 glycoprotein antibody, and last is lupus anticoagulant. Lupus anticoagulant matlab as per APLA syndrome can be seen in a patient of SLE, systemic lupus erythematosus. Important is which is the most important antibody for APLA? Most important antibody. It is anti-beta 2 glycoprotein antibody, which is the most important antibody for APLA. Choose with this anybody? Please remember. So, case of APLA syndrome, of choice क्या होगी? Lifelong treatment of choice. Lifelong क्या देते हो बच्चों? ड्रग. क्यों थ्रोम्बस बन रहे पेशेंट में? APLA में ये बच्चा क्यों गिरता है? Why there is abortion? This patient has high risk of thrombus formation. There thrombus formation in the placental vessel. If there is thrombus formation in the placental vessel, can the baby get blood supply? No. That is the reason there are recurrent abortion in cases of APLA. Understand APLA once. It will be easy. Okay? No issues with this. Preeclampsia bhi usi ki wajah se hota hai. As there is blockage, the pressure will be high. And what is preeclampsia? Increased blood pressure during pregnancy. Right? In short. So that's important. Aspirin lifelong deni hoti hai. And also be given to the patient. हो गया. Take a break, then we'll start.